Okay, good morning, everyone. Welcome to the July 2024 meeting of the board meeting of NHS Devon, Devon Integrated Care Board. I'm Kevin Orford. I'm the acting chair of NHS Devon. I took a post on the 10th of June when our previous chair, Dr. Sarah Walston, stood down from the role. We pay tribute to Sarah in a couple of papers on the agenda later, but at this point I would just like to say thanks to Sarah for her chairing of this board since its inception in 2022. And Sarah has been a hugely inclusive and accessible leader in Devon over the last 3 years. And a highly visible champion of the NHS and social care and the charity and voluntary sector in Devon. And genuinely, we thank her for all of that work and wish her all the best for the future. The agenda for today's meeting, we have apologies for the meeting from the Chief Nursing Officer, Penny Smith, and we welcome John Trevains, who is the Deputy Chief Nursing Director, who is deputising for her today. We welcome Alex Deegan, who is the Director of Primary Care, who's attending to represent the Chief Medical Officer's Directorate prior to the commencement of Peter Collins in this role in the autumn. And we're working with NHS England to ensure that our interim arrangements fulfil all of the necessary requirements between now and the autumn. We also welcome Sue Smart, Deputy Director of Commissioning for Out-of-Hospital Services. Sue's here to present the agenda item relating to children and young people's services. Thanks for being here, Sue. Hannah Pulisi is the Director of Women's and Children's Services Commissioning. She's not here at the moment. She'll be arriving around 11 a.m. and she'll be presenting the agenda item on maternity and neonatal systems stocktake. We welcome Mark Cook, who is the Managing Director for NHS England South West, and we welcome Alison Williams, who is the System Improvement Director. Matt Chetwynd is the Director of States. He'll join the meeting for the item on the Teignmouth Health and Wellbeing Centre later on the agenda. And to say that all board members are here in person today, apart from Bill Shields, our Chief Financial Officer, who joins the meeting online in order that he can be at a family commitment. So we also welcome members of the public who are viewing the meeting online today. And I'd just like to remind everyone that this is a meeting in public and not a public meeting. We do have some questions which have been submitted to us in advance of the meeting and which relate to the agenda items today. And we will attempt to answer those questions at the end of the meeting. And if we can't respond in the meeting, we will provide a written response and make that available to the public as well. There is a board meeting in private session which will follow directly after this meeting. In that meeting, we'll be discussing items commercial in confidence, which relates to the public agenda item on the Teignmouth Health and Wellbeing Centre, and we'll also discuss the initial work on the system infrastructure strategy and also a draft communication to the ICB from NHS England relating to system performance. So after those introductions, let's move on to the agenda proper. We have declarations of interest. The register of interest is at 1.2. Is there anything which anyone wants to add to those declarations or anything which we need to draw to the attention of the board relating to today's agenda? So if not, then let's note the register of interests. We have the minutes of the meeting of the 30th of May. I'm not going to go through those page by page, but are there any points of accuracy which anybody would like to highlight? So if not, then the board approves the minutes of the meeting of the 30th of May 2024. Thank you. We move now into the section of the agenda which is the citizen's story, and I would like to just invite Piers Tetley to introduce the citizen's story and then to follow on with the paper which is associated with that. Over to you, Piers.
Quite. Thank you, Chair. So I'm introducing the citizen's story today in my capacity as the Executive Lead for Domestic Abuse and Sexual Violence. The next two items are linked, so I'd like to thank firstly the 4 members of staff that have created the film today to introduce the importance of the sexual safety charter, which is the second item. And so I don't need to introduce them because they do a very good job of doing that themselves. And they do a far better job than I would ever do in explaining why the board signing up today to the sexual safety charter is so important. So I'll ask that the video gets played. Thank you.
I'm Colette Eaton-Harris. I'm the Interpersonal Trauma and Violence Lead for NHS Devon. So NHS England launched the Sexual Safety Charter last year, and it's a set of 10 standards that they're asking ICBs and trusts to sign up to fulfilling. And the standards cover a number of aspects: our culture, our training, our policy, and our approach to supporting staff. Last year, we started some work around sexual safety when we commissioned some training for ICB HR team and for HR teams across our provider services. And that training was a collaboration between ACAS and the Sexual Assault Referral Centre, and it looked very much at how we could take a trauma-informed approach to responding to sexual harassment.
My name is Louise Barraclough. I'm the lead nurse and the specialist safeguarding lead for Devon and Cornwall Sexual Assault Referral Centres. Trauma has an effect on the brain, and there are all sorts of reasons why victims don't necessarily behave the way people expect them to, and B, what they can actually remember. So your limbic system takes over when you experience something traumatic, which puts you into this kind of fear, flight, fright, freeze response.
So there are some real challenges in working around a charter like this. Sexual harassment and misconduct, it's often behaviours that are perpetrated when there aren't witnesses around. When that's not the case, when it is in front of other people, we have had a culture within the NHS similar to other organisations where sexualised comments, inappropriate behaviour has been to some extent normalised and accepted. It means that people feel very vulnerable in speaking out about it. They're unsure what response they will get. And once people have confidence in how an organisation will respond to sexual harassment and misconduct, people then feel much more confident about speaking out.
So my name's Penny Rogers. I work for Devon Partnership Trust, where I'm the Deputy Director for Safeguarding and Public Protection. We've been part of the National Initiative for Improving Sexual Safety on Mental Health Wards for a few years now. We were part of the national pilot. And we were one of the first trusts in Devon to sign up to the NHS Sexual Safety Charter. We have undertaken a number of strands of work, so we're both looking at the sexual safety of our patients, and many of our patients have histories of sexual trauma and trauma in general. And then we're also looking at sexual safety for our staff. So the NHS Sexual Safety Charter is predominantly focused at actually how do we ensure our staff are safe. The ability to feel confident in having conversations around those topics, the willingness to ask, and the confidence to know how to support someone when they make a disclosure is really key. So we also have some training that we're hoping to get launched by September around sexual safety, which will be offered to all staff.
HR have a really key role in supporting the Charter and supporting people to raise concerns and act on them appropriately. We want to be part of ensuring that the organisation is a safe space for people to work and share their concerns, and that they feel confident in doing so. HR can support and reinforce this culture in many different ways, including ensuring clear behaviour expectations are shared, starting as early as the recruitment and the onboarding process, supporting effective training on how to respond appropriately to disclosures of sexual misconduct or abuse. HR continues to work closely with groups such as the Freedom to Speak Up Guardians and the Staff Partnership Forum to ensure that staff feel safe able to speak up, and that we're aware of any potential barriers to this. And continuing to recognise the importance of legal compliance, capturing and reporting information to continually learn and improve. HR also play a really important part of ensuring that we have appropriate, specific and clear policies in place. Policies, for example, should really clearly outline behaviour expectations, how concerns should be raised and what can be expected when you raise a concern, as well as confirmation and clarity regarding really important points such as confidentiality and also being clear on wellbeing support that can be accessed.
So what I hope to see is that we have a workforce who are really confident and really prepared to speak out and challenge when they see something inappropriate or hear something inappropriate. And I also hope that on the ultimately rare occasions that we have people reporting that something has happened to them, that they tell us that they had a really good experience of the support that was wrapped around them and that they felt listened to, validated, and that we took their concerns really seriously.
Thanks, Piers. I wonder if it's worth going into the paper itself as well before we open up the discussion at the meeting.
Thank you, Chair. That makes complete sense. So I'm sure you will all support what the four individuals said a number of times during the course of the video, which is that our staff should feel safe in the workplace. That's a core principle that I'm sure no one would think otherwise. So the Sexual Safety Charter is a national initiative, and all other boards of NHS organisations in this system have already signed up to this. So it's important that today we consider that, and I hope that you will support me in signing up to the Charter. No organisation is immune to this. Indeed, as the paper indicates, and I'll take that as read, we've had 8 cases, individuals rather, that have expressed concerns through the staff survey result in the last time that we run it, at the end of last year. We have 2 cases. We've had 2 cases in the last 2 years, one of which was settled during a tribunal process. So we are not ourselves immune to this, and it is a really important thing for the board to make a very clear statement today that we have a zero tolerance for anything related to that, and that our staff should be safe in the workplace. So I think that's all I need to say. The 4 members of staff did a very good job, and the paper, I think, speaks for itself too. So I'll stop there. Thanks, Kevin.
Thanks very much, Piers. Sheena.
Okay, thanks. I obviously really value a charter that seeks to protect staff from sexual harassment and trauma, and absolutely agree with the long-term impacts that sexual trauma has on health, well-being, etc. I've got a question about what we mean by an intersectional approach to this charter, and I suppose what I would like some assurance of is that the organisation is both aware and prepared for the kinds of conflicts that can arise from an intersectional approach. So I'm sure we're all aware of the case that's currently in Darlington at the moment, where a group of female nurses did take their concerns about changing in front of a full male-bodied trans woman and felt incredibly uncomfortable about it, went to their organisation and were basically dismissed and told that they needed re-education. So there are 2, that's an intersectional conflict where you have 2 different rights. And I think it's really hard. And I just want to know, have some assurance that we're ready for that and that we are fully briefed about those conflicts and don't simply dismiss people. So just something on that would be great.
Shall I come back on that? Thank you, Sheena. So I think we're still probably all getting used to the term intersectionality. It's not. I think it was coined in the 1980s, and it's not been commonly used until more recently to describe exactly as you've indicated, that everyone's experience of discrimination is different, And essentially that's what it means, that we have to understand everyone's perspective if we are going to truly eradicate forms of discrimination or abuse or harassment. The specific example that you give, essentially we would consider each case on its own individual merits. We would take expert advice, which we have access to, and we would have to form, and we would listen to the individual views of the individuals concerned, and then we would have to form a view based on the very specific circumstances that are presented in front of us. It's quite difficult to, plan for every scenario, but part of the signing up to the Charter today, it makes a bold statement, doesn't it, about our preparedness as an organisation to apply the 10 principles contained within it, and have robust processes in place that enable us to make informed judgments when presented with challenging cases like the one that you've just described. It doesn't mean to say that we'll always get it right, but we'll approach it in the way that the principles are set out, listening, understanding, taking professional expert advice and making a judgment based on that.
Did you want to come back on that, Sheena?
I do, and it's really, really difficult, and this is such a toxic area, but what I'm hearing on the basis of that particular example is that we're providing no guarantees to either our staffs or potentially our patients of having female-only spaces. And that is potentially quite controversial in terms of, we know that mental health wards, mixed mental health wards, are associated with high levels of sexual abuse. And there is, although it has been toxified, I don't think that requiring private spaces when you're getting undressed it should be a controversial area. So I'm not feeling very reassured, actually, because I think if we're going to take each case on its own merit, we're not signing up to a principle of protecting biological women's dignity.
So is this on the same point, Liz and Judy? Okay, is this on the same point, Judy, or?
It's a response to what she was saying.
Okay, let's bring you in first then, Julie. Thanks.
So I just wonder, I hear absolutely what you're saying, Sheena, and these are a set of principles, and we need to be careful that the principles don't lead us down a difficult line. It seems to me that the way, and I think this is what I heard Piers saying, we need to make sure that it's safe for every individual, that there isn't one category that gets some priority over other categories. So I wonder if minuting that the needs of every individual will be taken into account in our decision making would mean that we couldn't end up with a rather careless approach on some issues as a result of what's the current vogue. So if we could use a phrase like that in our minutes, that would make sure, and we have some practice of doing that. We used to have an EDI group in the CCG days. We looked at the way in which the building development in South Molton was going to be suitable for, in those days it was toilets everybody was talking about, but arranged for them to be individual cubicles so that anybody could use them, multi-use. So there's lots of opportunities to do things differently if you focus on the needs of everyone, not just groups.
Thanks, Judy. Liz?
Thank you. I'll be brief. First of all, really welcome this. And as you said, Piers, this is something that's been through provider boards previously. And my personal experience of listening to staff have had really difficult experience in this area really reminds us of the importance of the impact on individuals, but also importantly, the impact on our ability to deliver services to our population. But if you're going to get this right, you also need to pay attention to the support that you make available to our staff. And in a constrained environment, it's often one of the things that goes. So I do think it is important that kind of focus on so what in the event that people come forward, speak up, as we really want them to do, and make sure that we've got access to the right support.
Thanks, Liz. Tandy?
Yeah, I totally agree with what you just said, and I think it's really good to see this piece of work come up. I see this as a set of principles, like Judy just said, but I think that what will make a difference is the actual actions that sit behind this. So if we say we're going to promote a culture that fosters openness, what does that in practice mean? Because I think this is something that people expect in work. Nobody expects to be sexually sort of abused in work, but I don't think it's something that we have had in the same way that we've had EDI, for example, that's been people, on people's agendas all the time. This is, I think, something quite new. So how are we, in mini courts, launching this to staff to make sure that staff are actually very clear that this is the environment we've just created and this is how we're going to deal with situations, apart from just hoping that they will report in that kind of sense. I think that we need a really clear communication plan to make sure that everybody understands that this is where we stand.
Mm-hmm. I'll come back on that point, Chair, thank you. Yeah, I think you're absolutely right. Part of the significance of the board signing up to the Charter today would be embellished by making that very clear statement then to staff that we've done that, and what essentially you're talking about, what Liz is talking about, is about creating a culture where people feel able to speak up, and when they do, they see that the organisation has acted responsibly to support them and do the right thing. And we will do that and demonstrate that over time as we behave in the way that I've just described. And this is the start of that, of making a bold, strong statement. We will have zero tolerance for behaviour that falls short of what individuals expect. Everybody expects what we expect as reasonable behaviour, but bearing in mind the conversation we just had about intersectionality, about people's interpretation of what they expect. So yes, communication is really important. I absolutely agree, and we will do that through our normal staff communication routes, and I'm sure Steve would be very happy to present that as part of the next staff briefing. Thank you, Tony.
Thanks. So I've got Donna, and then I've got Alison.
There's a foundation of understanding required, isn't there, before people can act, and so linking in with the work that we've been doing on EDI, I just wonder if there's an interconnectivity issue that should be referred to, because it talks about training, but I'm always interested in what's mandatory training, because this is something you need to work on year upon year upon year with every member of staff. So I'm just wondering if perhaps at a later report we can have greater clarity into how the EDI work and this piece of work are going to connect, but equally so in terms of what will the organisation actually expect in terms of mandatory training, and how will we review the quality of that on an annual basis, because it's ever changing, it's ever complex, but we need that commitment to the word mandatory, because unless we set that out and monitor it, we can have statements like this that result in no action and no monitoring. But I'll just say I'm delighted to see, and I think it should be noted that in terms of staff who have had the courage to step forward, I would hope that they have had some kind of follow-up, that we really commend them for that, because we know with all of this that what's reported and what's actually happening are two very different things.
Thanks, Donna. Do you want to come back on that issue of mandatory training, Piers?
I'm really happy. That's a really good suggestion. Certainly, the two things that how we go about the detail you've described about how we make sure that the training is effective, and how we connect that with our wider EDI structure. Both very good suggestions. Happy to do that, Chair. Thank you.
Thanks, Piers. Alison.
I think it's implicit in the policy as and the charter as it stands, Piers. But if the workplace is a safe place, then the likelihood is that if this is done well, then out of work sexual harassment and sexual abuse may also be reported through the workplace. So it's really just having some assurance that as part of the internal arrangements in the organisation, there are the connections to the out-of-workplace opportunities for support for staff, because work may be the only safe place, actually, for some people who are experiencing this type of abuse outside of the workplace. And as part of the communication of the policy, reinforcement of that might be really helpful and instrumental to people who are having out-of-work trauma, getting the help that they need.
Yeah, thank you, Alison. That's a really good point too. We are very fortunate. You heard from Colette Eaton-Harris, who's our expert, in-house expert in this area, and part of her role is to make sure that we have that connection between service and support for staff. But we can absolutely, as you say, part of our communication and the launch of this, we can make that really clear. Thank you, Alison.
Thanks, Piers. And just the final point on this then to Kate. Thanks, Kate.
Thank you. Sorry I was late. So we in Cornwall as well are talking about signing up to the sexual charter. I think some of the things that we're considering might be great if we could look at doing together. So we've got a zero tolerance towards violence at work, but we haven't actually explained that violence comes in many sorts of different forms. And we know that the national starting point for the NHS isn't very good, but we don't know what our local starting point is. So we're starting to think about how we could survey all of our women, but not just in the NHS, but in the local authority and in the voluntary sector organisations that we work with, including general practice, so that we know what our baseline is from when an intervention takes place. And then one of the things we're really worrying about is that some women, because of intersectionality, may actually be affected more by this than others, and what are we going to do? So getting people ready to tell us their stories is one thing, but then what we do with it after that is something else. So some of our colleagues are knee-jerking immediately to say we should tell the police. Well, women might not want that. So planning ahead what we might need to do should be the starting point of doing it. And I just think it would be really great if working across the peninsula we could mark ourselves out as a place where coming to work is safe. If home isn't, we can make sure we give you an environment in which you can share. So it'd be great to do it together.
I think Judy just wants to come in on that point, and then I'll bring Tandy in.
Sorry, just really quickly, we have to be very clear it isn't only women that experience sexual harassment. It is more women than men, but if we were doing something similar, I want us to be sure, and I'm sure you are actually in practice, not only looking at women who are affected by it.
Thanks, Judy. That's a good point. Tandy?
Yeah, just a final note that you might want to consider. I'm sort of just thinking about the changes that we've had in terms of new recruitments from out of this country. And I think that people come in from different cultural spaces where some of these issues are seen very, very differently. And that affects both whether women or men from those spaces will feel that they've just experienced something that we would think is not acceptable, or whether men or women might feel comfortable enough to say something that is not appropriate. So I think that maybe, I don't know, as part of induction or something like that, I think it would be really good to make sure that the standards are made very, very clear so people don't find themselves in trouble inadvertently or feel that they can't report something because they think it's acceptable.
Thanks, Tandy. So I think that we're hearing support for the Charter. What we're also hearing, I think, is that there are potentially some issues of implementation and communication. The kind of things that we've heard today are that we need to make this set of principles clear to people, so there's an understanding what they mean. There are issues around connection to the culture of the organisation to ensure that we've got a culture in which people feel that they can safely speak up. And we've heard there are wider connections to other policies and initiatives in the organisation. So I do wonder, Piers, whether some of these issues might be taken forward into the People and Culture Committee. I'll just wait for the test to finish. If they could be taken forward into the People and Culture Committee to particularly address some of these specifics and interpretation of intersectionality and how we help our workforce to understand some of the terms that are in here and understand how to work with them. Okay. If we leave that with you, and let's also just thank Colette and Sam and Louise and Penny for their contributions to that video, which was just really helpful in terms of framing the discussion that we've just had. Thank you, Piers, and your team for all of the work that you've done on the compliance with the Charter, and the board is therefore approving that NHS Devon should become a signatory to the Sexual Safety Charter. Okay, thank you, everybody. I omitted earlier in the meeting to ask for confirmation that we're quorate. Philippa, are you able to confirm that for us?
Yes, I can confirm.
Thanks very much. So moving on to our leadership reports. The Chair's report, my Chair's report is largely for noting. I would just like to add something to it, which is that whilst I'm acting Chair, we are exploring how we can bring in additional independent non-executive member capacity to backfill some of my previous work during the period that I am acting Chair. So I'd like to add that into the report and for the minutes. Most of the report is for noting, but if I can draw attention to the proposals for board subcommittee membership, which are recommended to the board for approval. Can I ask if there are any questions relating to that report? Frank.
Thank you, Chair. It's just one. I mean, I know this is a moment in time and we don't have a Chief Medical Officer in post until October, but they're not referenced on the various subcommittees.
Thanks, Frank. Philippa, is that something you'd be able to respond to for us?
They are. Perhaps not in not in the level of membership as previously, but definitely in the Population Health Inequalities Committee, the Chief Medical Officer's there. And I think, I can't remember which other committee they're in, unfortunately, but consideration has been given to it. But if we're not careful, the Chief Medical Officer ends up on every committee, so we wanted to make sure that we had a baseline of membership there, and then we'll review once they're in post.
Do you think there's any particular omission that's concerning you, Frank, in terms of Chief Medical Officer membership of any of the subcommittees?
No, I think it's probably
Okay, all right, thank you. Piers.
Thank you, Chair. Sorry. Just a small but important point. I thought the CPO was going to be included in the Finance and Performance Committee.
So I think the answer to that is that the CPO is in the Finance and Performance Committee, but not as a member. Am I right about that?
Yes, but we can make that.
But we can make that change if that's appropriate. Thanks, thanks, Piers. We'll make that change. Okay, so if there are no further questions or observations, let's note the contents of the Chair's report and approve the membership of the Board's Assurance Committees, subject to clarification of the Chief People Officer being a member of the Finance and Performance Committee. Okay, we'll now move to the Chief Executive's report. Steve, could you take us into your report, please?
Yeah, thank you, Chair. Before I start, I just wanted to acknowledge you'll see on the agenda today quite a few challenging and difficult issues that we're facing today. Now, whilst in themselves they are there's something we need to work through. I would, as those of you who are getting to know me know, I'm ever an optimist, that I would take a positive out of this, that we are starting to deal with some wicked and in some cases quite long-standing issues, and we're doing so in an open and transparent way. And I think that's a good sign for how this organisation needs to move forward. Clearly, there's still a lot of work to do to build a strong and capable ICB as we come out of the other side of the significant organisational change process, and also the strong system leadership that we're seeing develop. But I hope that what you see in these reports today is that we have definitely started on that journey. And I'm looking forward to the discussions as we go through the agenda today. I would just like to add my thanks to that of Kevin's for Sarah's time here. Sarah played a big part in bringing me in to Devon, and it was a great pleasure working with her while we had that opportunity. But also to thank Kevin for stepping into the breach. It's a big and sometimes quite daunting step, but Kevin, of course, knows us really well, has hit the ground running, and I've really enjoyed the time that we've been working together. So thank you, Kevin, for your support. In terms of the paper itself, I'll take most of it as read, but there's a few bits I just wanted to highlight. You'll see a relatively brief update on the organisational change process. We have strongly encouraged staff feedback, and I think we've had over 700 individual items of feedback. And that's important for us. We're in the act of considering all of that at the moment, and we will need to bring back a board discussion around the implications of that to a future meeting. I've also set out in there, as already mentioned, our new Chief Medical Officer starting, Peter Collins, starting on the 7th of October. And having thanked Nigel last time for his significant impact on the organisation, I'm looking forward to Peter picking up those reins. He's got really strong medical leadership experience. He's got a strong track record in strategy development and improving culture. Those are going to be two things that are very important to the mission that we're on. He's also, it came over very strongly in the interview process, a strong team player. He wants to absolutely be part of the ICB and the wider ICS team. So I'm looking forward to him joining us and focusing on some of those really big agenda items that he has in his portfolio. And I've also been clear in my discussions with him and our Chief Nursing Officer about the really important close working between them around the quality and safety agenda and quality improvement more generally. So I'm looking forward to Peter starting. Very grateful for Alex picking up and keeping hold of the brief in the meantime. Thank you, Alex. And also to congratulate Alex for his primary care appointment, a great appointment. So thank you, Alex. You'll also see that I've covered, as per some correspondence that went out to the organisation, some changes to our senior leadership team in relation to phase one. I won't dwell on those. We've had an opportunity to talk about them, but happy to take any questions. In respect of the additional support that we've brought in to help us with some of the challenges around our NOF4 exit criteria, at the time of writing the report, I think it was the triumph of maybe hope that we would have finalised the risk funding support. However, I think I just need to clarify for board today that we are still awaiting that clarification from the National Intensive Support Team. I'm hoping it's going to be positive, but as we stand here today, we're awaiting that. I may ask Alison just to say a few words on that in a moment. And then also to clarify in relation to the public health post that's being funded in a similar way, that's a separate regional agreement, although it is being badged as part of our RSP efforts. So I think just hopefully that's helpful. If I can congratulate John Finn as well. There's a lot of good things going on in the organisation, and I think a time when we're under such pressure, it is easy just to focus on the difficult areas. But it was great to see John and the team showcasing the achievements that they've had at the NHS Confed on the One Devon pilot, and actually they took the whole system leadership group through that earlier this week, and it's really impressive. Sets a really good platform for how we want to move forward on a whole range of issues, and I've told him to be ambitious about what we can achieve next year. There are a number of other things in my report, Chair, so I'm just happy to take any questions on what I've said or anything else in the report.
Thanks, Steve. Are there any questions for the Chief Executive? Sheena.
Yeah, thanks, Steve. I'm just looking at the annex and the ICB operational plan commitments, and I do understand that this is a work in progress. But I'm just sort of wondering whether, as a board, we could start to look to. There's a couple of things missing here for me. One of which and it's hard to work out metrics to explore that, but I, as you know, sort of feel quite strongly that we need to shift the balance of care towards prevention, early diagnosis, care within the community if we're going to start both actually improving quality of life but also saving costs. And at the moment, our metrics are very, very siloed. They're siloed around separate areas, and I don't know if it might be, if we could give a bit of headspace really to thinking about how we might capture evidence of that shift. I think that'd be really, really helpful. I can't see digital in here. And again, I'm absolutely convinced that if we don't start doing something about digital, technology-enabled care prevention at home, as opposed to through EPRs, we're probably never going to, hit that sweet spot. And the prevention stuff's just very limited.
If I can respond to that, I agree wholeheartedly, Sheena, on those things. This is a point-in-time snapshot, I think, of some specific issues. I am hoping to come back for a board development session where we can start to set out the overarching priorities that I think we have. I know in Cornwall they call it channel shift, the sort of the push left. I think we're all in very much that same space, and that is fundamentally built on a population health approach. I think issues like digital and also how we structure our infrastructure and make sure that that's fit for purpose in the right place and we've got the right equipment and so on is also going to be important to that. So I'm hoping timescales are challenging, but we need to have a discussion as a board about what we think all of those strategic challenges are, so we can start to bring them together in a way that breaks down those silos between all the areas of work, because they are all interconnected in the end. So I'd hope what you'd see here is a point in time, and actually as we start to move into the planning round for next year, we'll start to see much more join up across it.
Thanks, Steve. So if there are no more questions for Steve, then let's note the contents of the Chief Executive's report. Moving on to the National Oversight Framework, we have the progress report on the requirements of the NHS Oversight Framework. I'm going to invite Anthony to take us into this paper. Thanks, Anthony.
Thank you. So I'm hoping this is going to be a team effort, because I was only expecting to talk about UEC and elective, but if I cover those off, and then perhaps we can take any questions around the other elements. I'm taking the report as largely read. In terms of UEC, which is where I seem to spend a lot of my time at the moment, pleased to say actually we've seen a continued improvement in our metrics, particularly around 4-hour performance, and that's across all of our providers. You'll notice some differences in reporting. We've actually started to put our rankings in against national performance, and that's been a key measure in terms of how we're tracking progress. I think one of the key things for us is linking both the ownership of the issue, the environment in which the issues happen, but also the leadership, and that's where we're really seeing some demonstrable changes in terms of UEC performance. So and just to sort of reflect on that, what that means is that we've seen a continued performance across May, seeing that into June as well, which obviously isn't reported here. We did meet our submitted trajectory, which is a big improvement. And actually, if you track this back since the last time we actually got over 70%, that is pre-pandemic. So huge improvements across the system and across our provider organisations, which is very, very good to see. In terms of actually our ambulance performance, though, not quite the positive story. And although we have seen improvements in our handover times, we haven't seen that track through to our Cat 2 responses. So again, some further work is required there. As a system, we've signed up to a regional task and finish, or task force rather, to try and improve against both Category 2, but also our overall ambulance handover times, and a commitment to get back to a 45-minute standard, recognising national 15-minute standard, but actually making sure across the whole of the region we are moving as one in that piece of work, and working very much with our colleagues from SWAS. UEC, though, continues to be challenged, and we have challenges coming forward, both in terms of collective action in primary care, and although that will have an impact in terms of emergency services, actually it will also have a big impact in terms of our elective care performance. We haven't modelled that necessarily in terms of our trajectories, and actually, as you can see across our elective performance, we have made continued improvements and have met our trajectories for the last month. We're just now starting the work in looking at the impact of collective action in primary care and what that would mean for elective performance. Obviously, that is subject to ballot and referendum at the moment. We will have further information in the next few weeks, and we're working with our providers to put in all mitigations that we possibly can against what is a wide-ranging suite of potential actions that could have an impact on elective care as well as emergency. In terms of the other elements within our NOF4 paper, I'm happy to hand that over to others or to take questions.
Thanks, Anthony. I thought perhaps what we just do is bring in Bill, if there's anything you want to say on this paper relating to finance. I appreciate we have the finance paper later on the agenda, but is there anything at this point that you want to, any points you want to make, Bill?
I think there's a general overarching point, which is that you'll see the assessment across each of the areas is amber, and that marks a change from what we've seen before, and that's largely due to the elements that Anthony's covered in terms of the improving performance that we've seen in UEC and continued strong performance in planned care. As for finance, we are on plan at month 3. I'll go through this in more detail when we get to that part of the agenda, but that plan is one that's back-ended. It's the plan that we submitted to NHS England, and that's understood that there's a requirement for us to deliver higher levels of cost improvement as we go through the year. And so while we're on plan at this point in time, taking account of the impact of industrial action, there is a significant challenge for us going forward. I had a long conversation with the Regional Director of Finance yesterday, and again I'll cover this in the finance element of the agenda, but there are concerns about the level of risk that are inherent in our plan, and it's really important as we move into month 4 and beyond, we don't just remain on plan, but we start to get ahead of plan and we can deliver higher levels of cost improvement. The expectation and the requirement is that we will convert more of the cost improvement to recurring than non-recurring, which has been the pattern in NHS Devon in the past. We've typically delivered 70% recurrently, 30% non-recurrently. That needs to improve. But also, we need to ensure that those elements of unidentified cost improvement are identified as we go into month 4, and there's a requirement for us to do that by next month. So an awful lot for us to do. On plan at this point in time, huge risk in the plan, as we were clear about from the outset, and we're doing everything that we can, including having monthly assurance meetings with all of the CFOs. We did that on Monday, a 4-hour meeting going through in detail, not only the financial elements of their financial plan, but also workforce, looking both at full-time equivalents and the cost of the workforce, as well as agency costs, to ensure that those are also on plan. So a lot of assurance going on. But at this point in time, we have a long way to go to deliver the financial plan.
Thanks, Bill. I think it's just worth highlighting the point that you've just made, that the operational plan, which we signed off earlier in the year at the board, and the annual plan, which is with us today, they do provide for the delivery of all of the requirements of the oversight framework. So let's just note that reconfirmation there. Steve, I think you want to come in on this before I open this up. Oh, sorry, Alison, I'm sorry.
Sorry, Chair. Could I just take the board to item 16 at the bottom of page 49, and the 3 bullet points just over the page? The board will be hopefully reassured, if not assured, that the middle bullet point, which refers to a plan to achieve financial balance in 25-26, the discussions with Region and the national team mean that that expectation has changed. So the actual expectation now is that the plan for 25-26 will demonstrate significant improvements in the financial position, not balanced in 25-26, and that the expectation is that by the time we get to the board-to-board meeting in October, there will be a plan that will demonstrate in the following periods what the actions will need to be and the timescale within which the financial balance will be achieved. So that's shorthand or longhand for not expected in 25-26, improvement, significant improvement in 25-26, but over the 3-year period, there's the ability to demonstrate that financial balance will be achieved. Can I just check with Mark that our interpretation and Bill as well, please, that is our understanding?
Yeah, thank you, Alison. Thank you, Chair. Yes, that's right. If the original letter that was issued, both on the back of the board-to-board conclusion and the planning close-down letter, I think were both reissued with a slightly amended form of words, which is, I think this paper has the original form of words, so it's probably just worth minuting the new form of words that was issued in line with Alison's point that she just made. I guess the other thing is that needs to go hand in hand with the board-to-board meeting in October of the strategy work that's being undertaken at the moment, which will link to things like the requirements around capital investment, service changes and so on. That needs to be ready to be presented to the board-to-board meeting in October. Thank you.
Okay, thanks for that clarification. So we'll just ensure that in the minutes we're noting that that middle bullet point in paragraph 16 has been superseded by a new correspondence with NHS England that our 25-26 financial performance is about significant improvement rather than balance. So Bill, is there anything you want to add to that clarification?
Yeah, a couple of points, please, Chair. We have developed a very high-level medium-term financial plan, and that shows a number of scenarios in terms of what the ask is between now and 2028-29. That shows the requirement for significant improvement, both in terms of the position next year, what that looks like, and what that will mean for levels of cost improvement. The board, I think, should be aware that we're still looking at significant cost improvement. We're looking at CIPs across the system. Once we take account of CIP within organisations of between 175 and 200 million pounds to achieve recurring break-even even over that period. So the levels that we're looking at this year will be very similar going forward, and that's why we need some key strategic moves, as they've been signature moves rather, as have been described by NHS England, in order to take that forward. We have started to populate the medium-term financial plan with those system-wide schemes, but there is quite a long way to go. In my discussion with the Regional Director of Finance yesterday, the likelihood is that we will have to present the detailed plan that will be discussed at the board-to-board in October by no later than the 16th of September. So we have 6 weeks to achieve this piece of work, and I just want the board to be aware of the size and scale of the effort that we're undertaking at this point in time.
Thanks, Bill, and thanks for that articulation of the risk and the mitigating actions that we're putting in place to get us to where we need to be for the middle of September. Can I bring in Donna, please?
Yeah, fully accept in terms of, delivering base value, but it concerns me to see a financial plan that's separated out from risk in terms of risk to patients, risk to leadership capabilities and staff, and you cannot separate the two out, because we don't want to be in a hindsight situation when we have to do things at pace and scale and then realise that we've created something bigger and greater linked to outcomes. So I'm really concerned with the scale of this financial challenge, and albeit accept it, and we're working all closely on this, but I just find it really concerning with the scale of it that there is not some risk register in terms of statutory requirements, perhaps in SEND or in mental health, or a range of areas that bring risks to staff safety and wellbeing, which we've talked about earlier, and also in terms of the people in the system at providing services too. So I think there has to be something that goes with that because of the scale of the challenge that we're facing. I don't know how we do it, but perhaps for the future, but I'm really concerned as a board member that it's separated out.
Thanks, Donna, for raising that. And so I'll ask Steve to respond to that. I mean, obviously, we've got the annual plan later on the agenda, which will perhaps address some of that. So without going into that,
I'm going to pass to Graham.
Okay, sorry, Graham.
Yeah, because I think I'm building on your point, Donna. So, look, I think we all recognise the importance of this. We all understand the complexity and the challenges. And I think we talked last time about green shoots. So I'm pretty more comfortable that we are seeing those through this report. This report, though, is a progress report which talks about where we need to get to, who's responsible, and our current status. And there's a limited amount about the future in it. There are a few words of narrative, but for me, I haven't really got to the grip on where we expected to be at this point in time. Are we on plan or not? So, Donnie, you've just raised the finance. I mean, 16% of the year's gone, 37% of our deficit's been incurred already. So, as Bill's already said, it's clearly backloaded. There are some critical assumptions underpinning this, and I know we've done a lot of work on drivers of deficit and benchmarking and the like, but if we're going to have reduced expenditure, reduced headcount and performance improvement, it has to be around productivity. So there's some critical assumptions in here, some critical success factors, and probably some barriers to achieving that, which with the best will in the world, plans don't always deliver, things happen. So I very much support that requirement of having a better expectation about where we get to when. Are we on track or not? Are we deviating, and what are we going to do about it? Which I think does build to perhaps a better grip on the risks and the mitigations. So Hope that helps.
Thank you, Graham. But Bill, I'm going to ask you to respond to that, and then I'll bring in the Chief Executive, and then I'll move to Judy.
So I think there's a number of things. In terms of the risk register, risk and mitigation, I mean, I think that we should take some assurance from the IQPR report that we look at quality and performance and finance together. All of the investments, disinvestments, changes that we talk about, we're very clear that there needs to be an quality impact assessment. So it has to be consistent with that, rather than just reducing expenditure and not being focused on the impact on quality and patient safety. So I would want to be really clear and state that at the outset to provide some assurance. We've also had discussions within the executive team about the risk register and making sure that that's much more comprehensive and takes into account the risks that are live in terms of delivery of the financial position. So that's not to say that this is not a very, very challenging financial position. The position across the NHS is extremely challenging, and we are one of a number of systems who have a challenging position to get back to recurring financial balance. In terms of the points made by Graham, absolutely agree. We have a plan that requires us to deliver high levels of CIP as we go through the year. Some of that towards the end of the year will be non-recurring CIP, but each of the organisations is very clear about what the ask is. And at the system leadership group that was held on Tuesday, they were asked to reconfirm by the Chief Executive their confidence in delivery of the financial position. We're confident of the position that the ICB will have to deliver. There is a requirement for us to increase the level of saving and to reduce the level of unidentified CIP, and we have plans in place to ensure that that is the case. And each of those organisations, as I've said, provided assurance that they had a clear plan to get there. That does not mean that it will be straightforward, and that does not mean that there aren't significant risks. But at this point in time, we have received that assurance, and I'm sure the Chief Executive will want to add to that, because we were both in the same meeting when that discussion took place.
Thanks, Bill. Steve.
Bill, yeah, you've covered most of my points, Bill, but I will come in on a few. I mean, you're right that, as both Graham and Donna have said, this scale of financial challenge and indeed the performance challenge brings its own set of risks, both to quality and also, of course, to our staff as well. That is something which we do try to triangulate and manage, and of course that's at various levels, one at the ICB level, but also within each of the individual trusts. There are quality and risk management processes wrapped around their individual plans as they were set out at the beginning of the year. But that's not to underplay that there are always going to be risks when you're dealing with this level of financial and organisational change. I think on Graham's point, at the beginning of the year, the robust process that Bill led to take the organisations through the SIP requirements, it was clear that there was a significant productivity component to that, and that was made up of a number of things. In some places, it was about increasing productivity or increasing elective spend through productivity in order to attract additional ERF money. In other places, it was more traditional, trying to ensure that we had the most efficient way of doing things. There were also other elements within that, particularly around workforce, our agency workforce spend and so on, which you could argue is part of the sort of productivity efficiency element, but is to ensure that we are bearing down on workforce costs while keeping a substantive workforce that we need. So I think those things do need to continue to be attended to, and we do need to continue to square them, because it is a massive challenge. As Bill said, we had our senior leadership group meeting on Tuesday with the system leaders. It was a sort of a light version of it because we're doing our formal meetings from August, but we did deep dive into all of the areas where actually we only focused on the adverse variances, which you can understand, but because there are green shoots and there are things that we should be positive about. But in those areas, we've agreed with each of those providers at our first locality delivery group meetings that I'm chairing in August, we will deep dive into those issues to assess confidence in being able to get back on plan, and in relation to the back ending of some of the challenges, confidence that we understand that we have plans in place to be able to rise up that curve as it starts to get steeper. So we'll be doing all that through August. There are a couple of other things, if I may, Chair, just while we're here. The issue around collective action, I did have an opportunity to meet with the LMC informally earlier this week. I have asked Alex to put together a paper to come to EXCO, and I think we then need to think about how that gets to board, just about the sort of the areas that are being looked at, what the risks and impacts will be, and what the any mitigations might be on it. I have to say my impression of the discussion I had with the LMC is they are being very fair and balanced in a very challenging position for themselves, and want to be absolutely open with us about what they're planning to do. Clearly a difficult situation, and one that will add to the challenges. But Alex, I know you've had some conversations since, whether through with the Chair's permission you might want to say a few words on that.
Yes, thank you, Steve. Thank you, Chair. Essentially, there are 9 potential collective actions that primary care will be taking in the future. We've got 118 practices across Devon, and one of the complexities around this is that every practice could choose to do all 9, 1 or 2 or 3 of them. So it's going to be quite tricky for us to ascertain exactly what the impacts are. Yesterday, we had our first kind of internal meeting with regards to this. Essentially, we're being asked to set up essentially an instant management response to it, and we'll be having twice weekly meetings to understand the implications and mitigations going forward. And as Steve says, there'll be a paper going to EXCO, and we can bring it back to board in due course.
Okay, thanks, Alex. Thanks, Steve. So with an eye on the time, I'm going to bring in Judy, Alison, Donna, and then I wondered, Piers, if after that you just want to say something about the workforce data. But over to you, Judy, first.
To some extent, my point builds on what Graham was saying, but the theme I've always been concerned about is implementation. So I have one concern, which is about our capacity to implement, particularly when we add our discussions on the annual plan and other areas where we absolutely have national legal requirements to meet agendas. So we can maybe pick that up later. So capacity. I am nervous about areas where we don't have control, and we've just discussed the collective action, or indeed the industrial action from junior doctors that goes on. We have no control over that at all. There is nothing we can do about it other than mitigate the consequences locally. And so at some point, I think we need to be very clear about where we don't have control. And lastly, I would like to see in future that in the conclusion, and the 3 areas, the 3 areas at the moment, 2 of which are taking assurance. So we're taking assurance about plans and processes. I really feel that you are working in an incredibly focused way on this, and I'm very supportive about that. Take assurance on the risks. I have earlier seen risks that are considered, but as Donna says, it's probably a good idea if we get those regularly. But I'd really like next time to be taking assurance on the progress on implementation, so that we are very early in the year saying to ourselves, is this actually going to happen by the end of the year? So I don't think I need responses. I think those are just points I would want to make.
Thanks, Judy. Alison.
If I could just quickly come back on the sort of performance against trajectories and turn to the UEC and the elective performance for a moment. The performance against trajectories is monitored weekly through the Tier 1 meetings, so there is a very significant rhythm and drumbeat of tracking the performance against trajectory. And it's important to note that pretty much across the board at the moment, the organisations are on trajectory for where they set out to be and where they said they would be at this time of the year. And that is a real positive when compared to previous years in Devon. So I think the board should take assurance from that. Specifically on UEC, the UHP position on UEC, as you know, has been the one that has really struggled to be addressed through Devon. There is now a very detailed and I have to say comprehensive and good improvement plan. I would suggest, Chair, that it may be useful to call that into your Finance and Performance Committee to have a look at, because I think that would give you some significant assurance that the improvement trajectories are backed up by very real action. And if I can give you an example, their acute assessment beds have never been right-sized to fit the daily medical take, and that is being addressed. and the changes are being implemented on the 29th of July. So it is that significant a change that will then enable some of the step changes. So I think it might be helpful for the board to have a look at that. The sort of reconciliation between some of the headcount and challenges through the CIPs and some of the requirements for performance improvement in UEC and elective care are not necessarily absolutely linked. The elective performance is backed up by ERF income, so the additional work will attract the money, so that is not cutting across the CIP programme. And for UEC, for both TSD and UHP, it's not revenue but capital and space that is the limiting factor. And just to give some assurance that there has been some active work with Region and the national team to address solutions for that, which we are hopeful we're going to get positive news around that, which could actually mean that some of those changes are delivered in this financial year. And then finally, on the leadership capacity, just to also report that the priority for the RSP funding for both the ICB and the trusts themselves is about providing additional capacity in programme management and in clinical leadership to support delivery. We're expecting the first tranche of that, about £1.5 million worth, to be confirmed within the next 2 weeks, and that capacity will be put in very quickly, as referred to in Steve's report earlier, to then support delivery. So I think it may be worth just a round robin on the detail of that through the Finance and Performance Committee, which will give some greater assurance then up to the board.
Thank you, Alison. All noted. Donna, please.
Yeah, you know, this is a public board, and I would really hope that all the staff and our colleagues involved in this board have got line of sight on the decision making here. I still didn't articulate it earlier. I think being in this kind of scale of financial challenge creates stress and wellbeing issues on everybody at every level, including people in this board. So I think there's something missing, because ultimately at the end of the day, this is about people leadership. And there's nothing in this paper that references the impact on some of these things on our staff, board members' well-being. So I still think there's something there, an assurance that, for example, some of the areas are self-assessment. We should have a peer partner working with us as we go through this to keep that line of sight on the people in the organisation and how they're managing responding to this. So I still feel that it's a very, and for the public looking at this, I would be asking these kind of questions and how we articulate that to get more of an honest, transparent articulation of the challenge and the impact on the people leading it. So it's just in terms of we are improving, we know that, and my goodness, has it been a journey and everybody involved in this. But I still think that linking into what we said earlier about a safe workplace and people understanding the challenge and the impact, and all the colleagues I work with in the system here, that we need to articulate that as part of what we're doing. Because I think it's important for our national colleagues to understand that and to be clear about that, because we've been at this a long time with lots of skills and abilities. It requires resilience and all these things. So I still think that this report just separates it out and doesn't capture the human element of what this means for the staff of the organisation. So perhaps for the future we need to try articulating that, especially for, and also understanding it. There's something for me here that if I was a public listening, I'd be thinking, what does this report really tell me? And so if there's a summary page that articulates in a financial document, I think it's helpful to have it, because it's very detailed and it's a lot of reading. So just a few points, because I'd like us to see us improving in this area.
Thanks, Donna. Before I bring in Steve to respond to some of that, there's a point I did want to make about this, that you know, the oversight framework doesn't represent everything that that we're doing as an organisation. So as we go down the agenda today, we've got the annual plan, for example, which I think provide some of that connection to the impact of this. So this is just one part of what we're doing. The impact of that, I think, we need to bring into other pieces of work. But Steve, is there anything you want to add to that?
You've kind of said it, Chair, but yeah, Donna, I guess it's a good point. I absolutely agree with the principle. You can only put so much in one paper, and actually reading the board papers in the round, I think, gives a sense of both the scale and some of the things that we're trying to do. What is missing, and I think I accept this, but there is work going on in the background, is when I just look at the ICB or as an organisation, the stresses and strains that this places upon our staff. There is a board and organisational development programme that we're putting in place, partly coming out of the organisational change process, which in itself has created quite a lot of stress and pressure for our staff. That's going alongside all of this. So we want to bring that back to board for reassurance. And of course, each of the providers who will have similar, maybe bigger challenges, particularly in some of their frontline departments, will have their own staff health and wellbeing developments. I am meeting with all the organisational development leads across Devon shortly to talk to them about what more we can do at system level to be able to convene and do some of that stuff. But looking after our people in these difficult times, I think, is absolutely a key priority for us.
Thanks, Steve. Just quickly, Piers, I think it's just worth highlighting some of the workforce data in this report to just bring a bit of workforce context to what we're doing here.
Thank you, Chair. And Donna makes a very good point. I won't repeat things that Steve has said, but we must continue to have at the forefront of our minds the impact on people. Right, some reassurance. We do have a rhythm, as Alison mentioned, not related to people necessarily in your example, but we do have a rhythm of regular meetings with chief people officers from around the system and chief finance officers, so that we link the people impact with our performance, and we can begin to track in the fullness of time the impact on productivity, as Graham has mentioned, others have mentioned too. To give to reuse the phrase that Graham used earlier about green shoots. There are some green shoots too in the workforce area, so it's not all perfect yet. We have clearly an awful lot more to do, but the system has been working extremely hard at reducing agency spend, for example. That's one of the key objectives to get down to. We set a target in our operational plan of 2.1% of staff costs. We're currently at 2.4%. So we are adverse to plan, but that, being on a journey, shows a significant reduction over time, and the level of granular detail that we have now available to us to understand where that spend is occurring and creating that adverse position to plan is very good, and certainly considerably better than last year. And so we have the opportunity to make improvements, and that's the green shoot. Everything is about getting better each time. This time last year, at the end of month 3, we were more than £10 million adverse to plan. This year, we're just over 3 million. So it's not acceptable, it's not good enough, but it is in significant improvement, and that's not me or the CPOs. It's a collective effort around the system, so therefore we're not working in isolation. We work closely with operations, we work closely with medical and clinical leads, as well as finance. So it just gives you a bit of an indication of some of the numbers. We are well below plan in terms of whole-time equivalents, and that may be one of the factors we need to dig into, because although that's a positive thing from a financial point of view, we're spending less on our substantive workforce. It may be an indicator that we're relying a bit more heavily then on bank and agency. So again, any position where it's either more positive than plan or adverse to plan, we're digging into. We have, for the first time, the data and information to be able to inform those discussions so we can fix things. So, yeah, just a very brief update, Kevin. Thank you.
Thank you, Piers. And final comment to Liz, please. Thank you.
Thank you. So I just wanted to pick up on the opportunity I have, because I think we do have an opportunity as an integrated care system to create the conditions for success. And the opportunity as leaders to create those conditions comes in about how we work together. And I think some of the work that, Steve, that you've started to lead around the Leadership Compact that holds us to account for creating those conditions as a wider system is something that we need to continue to build on, because it's going to enable us to bring people with us on what is a very challenging journey.
Thanks very much, Liz. So if we move to the recommendations of the paper, and the first recommendation is that we are asked to reconfirm our commitments to the improvements in patient access to elective cancer urgent and emergency care service, which are required to meet the exit criteria of the NOF4 category of the NHS Oversight Framework. We're agreeing to this recommendation, I think, in the context that the National Oversight Framework priorities don't represent everything that we are doing as an ICB, and we will be discussing that further in the annual plan report. I think we have received assurance that the operational plan and annual plan agreed by the board, whether the operational plan agreed previously by the board and the annual plan that's on the agenda today do provide for delivery of the oversight framework requirements. Is the board happy to support that recommendation? Okay, thank you. We're also asked to take assurance from progress reported to the end of May that system plans and processes are in place to address the financial and service imperatives of the NHS Oversight Framework. I think we've received further assurance in the meeting today that indicative data for June continues to indicate right progress, and we've received further assurance that we've got processes in place to focus on system performance to ensure delivery, and we've had a request that in this report at the next meeting that we have a focus on implementation of the plans. Are we happy to approve that second recommendation? And then finally, we're asked to take assurance that the remaining risks to compliance with the NHS Oversight Framework requirements are properly identified and that we have appropriate monitoring processes in place to facilitate the risk mitigation. I think we've heard in the meeting today that we have weekly monitoring of access numbers at a scale which we haven't had in the past. We've heard of detailed and comprehensive implementation plans on UEC, which we agreed that we will take into the Finance and Performance Committee. And we've heard of the processes that we're putting in place to address the significant risks around cost improvement plan delivery, which we've heard is back-ended in scale towards the end of the year. Are we happy to take assurance that we are managing the remaining risks? Okay, thank you very much, everybody. We now move on to the section of the meeting which is about approval and endorsement, and the first item in this section is the Teignmouth Health and Wellbeing Centre item, and I'm going to ask our Chief Executive, Steve, to take us into that, and I'm going to invite Liz Davenport to say a few words about this as well. Over to you, Steve.
Yeah, thank you, Chair. If I can just start by welcoming Michelle Smith. A great pleasure of meeting you the other night in Teignmouth. It's good to see you here, Michelle. The board will be aware, and the paper describes the difficult situation that we face in Teignmouth, and it sets out the decision that this board is being asked to make today. This is a scheme that many around the table will know has got had a long and difficult history, impacted by many things, and not least COVID and the inflationary issues that have been felt across the whole country. I think a scheme also, it's fair to say that everybody was doing their very best to make a reality. A case of perhaps optimism, bias, a desire to keep trying despite mounting challenges, I think, have led us to where we are. So I would like the board to just acknowledge that there was no malicious intent in any of this. People were trying their best. That does mean, though, that we have persisted too long with a scheme that wasn't able to be delivered, and now we face the decision that we need to make to change course on this. And I probably should say, and I know Liz will absolutely support this, that whilst the capital solution is not in itself affordable, the principle upon which that capital ambition was based, this idea of an integrated care system in the Teignmouth area, indeed across the Devon system, is something we're not giving up on. We've got to find an alternative way now to be able to realise it. I also want to acknowledge, and I think it's right that we acknowledge, that despite the motivations and the best of intentions from everybody involved, we have let Channel View Surgery down, both us and our predecessor organisations, in not living up to the commitments that we gave them at the time. And we must learn lessons from this, and we will do a formal partnership lessons learned process to ensure we understand what went wrong and try to avoid it in the future as part of this experience. So the urgent issue now is that we need to secure the short-term future of primary care and the Channel View practice, and then work with them in partnership on a new longer-term solution to secure services in the town. But the first step we have to take in order to be able to do that work is to confirm that we do not have the system capital available to be able to undertake the scheme as currently described, and then to formally communicate that to Torbay South Devon Trust in order that they can then make the next decision around the future of the scheme, I believe, at the end of this month. With your permission, Chair, I'll hand over to Liz.
Thank you, Steve. Thank you, Chair. So I would echo your points. We started off this journey because we believed in the model of integrated care that brought primary care, community services together to deliver for our local population, and it's an ambition we still hold on to. And I think all of our organisations, the CCG as before, the ICS and us as an organisation, alongside our partners in primary care, Channel View in particular, have been really energetic and enthusiastic about it. But the reality is that the affordability became a really critical issue for us, not least because of the costs having escalated considerably over that period of time, particularly when you benchmark that against a previous health and wellbeing centre that was delivered in the Dartmouth area for £5 million, and it just really kind of highlighted the issue around the finances. And I would want to apologise to our colleagues, and particularly our colleagues in primary care, who have been such enthusiastic participants in helping us find a solution and who find themselves in a difficult position as a consequence of the likely decision here today, and it is beholden on us to continue to work with them. But what I don't want us to lose sight of is the principle of integration is still the right principle. And it might not be in one building, it might not bring all of our services in one place, which was our vision and what we got very excited about. But it is well within our gift, particularly on the back of the relationships that have been established over the years we've been working together to create that integrated model, albeit in a slightly different way. And I would commend that approach to the board. Thank you.
Thank you, Steve. Thank you, Liz. Can I open up for questions for Steve and Liz? Kate.
I'm going to make a comment really more than a question. So the model of care that you're describing for Teignmouth is most definitely the model of care that we're pursuing across the whole of Cornwall, and the evidence base around better outcomes for people is really compelling. So I just wanted to endorse the direction that's being taken.
Thanks, Kate. That's helpful. Okay, Frank.
Thank you, Chair. As a GP who has been in exactly this situation, I would just like to commend the practice for how they have behaved throughout all of this. They are the only people who have themselves covered in glory. The rest of us are not. Having said that, no one, as Steve has said, no one went out with intent to make this not happen. And if anything, we tried to make it happen for too long. I was in exactly the same situation when Tiverton Hospital was first suggested in 2000, and it wasn't until 2010 that we were told we could not actually build on that site additionally to the hospital for our practice. Actually, what the practice needs now is clarity. This decision is really difficult to hear, but actually then you have new opportunity. And I think the opportunity is that you go back and look at the whole, all the options again, to see whether any form of integration can happen. But we absolutely must support the practice through this. They have behaved impeccably, and we do need a very short-term solution and a longer-term solution as quickly as possible. There are lessons to be learned, but the similarities in those two processes were basically it took too long and costs escalated rapidly on both projects because of that length of time.
Thank you, Frank. I'll bring in Judy and then Sheena, please. Judy.
I just wanted to endorse everything that Frank said, and particularly that the practice have been extremely committed to this project and understanding of some of the challenges. I want to say that I will be supporting these proposals because I'm assured that our executive team, the fact that Steve has been to meet the practice, will ensure that we give them the support they need in this period of finding an interim solution and a long-term solution.
Thanks, Judy. And Sheena.
Yes, thanks. I also, it's a really difficult situation, and I feel assured that that priority of actually sorting out primary care in this area is being prioritised. It's a broader point, actually, from an inequalities perspective, which is that this is unfortunately, and to nobody's fault, this is the second opportunity that we've had to draw together not just primary and community services, but potentially sort of other preventative services, citizens' advice, a whole load of social care, really important integrated services which particularly benefit people who perhaps are less advantaged, who have more complex needs. And with the loss of the Cavell and now this, it's just really disappointing, really. So I'm really pleased to hear that you're going to continue to pursue that integrated vision. I suppose I just hope that we can be alert to the fact that having that integrated vision in one building could have actually possibly been both more cost effective and reached out to that group of people a little bit better. And we need to start to include that intelligence into understanding the losses as well as the gains. We can't change what's happened, but perhaps for our future strategic planning, we can start to think about this as a model and think about how we can potentially realise it.
Thanks, Sheena. You're articulating what a lot of us feel about this, and I think your point around how we integrate this into future planning is a really valid one, which we'll take forward. We just need to just note that some of the technical details in the report will need amending, and I'm just going to ask Philippa to give us an indication of what those are. Thank you, Philippa.
Thank you. So we've been informed that we've got a number of inaccuracies in the report in relation to the independent reconfiguration panel's role in particular, mostly around who sought clarification, the role of the Secretary of State and the delivery of the IRP advice. So I propose that we circulate those in detail and correspondence to the board, and then we move them into the minutes of this meeting to make sure we've got a record of those.
Thank you, Philippa. That's helpful. So I mean, we all regret the position in which we find ourselves on this, and we've heard that in the discussion we've just had. I would like to thank the ICB team and also the team at Torbay and South Devon Foundation Trust for the efforts which have been made to try and find solutions to the capital financing of the proposal for Teignmouth, and also I do want to thank the Channelview medical group who have acted in good faith throughout this journey, and as Steve said, we do apologise for the impact of this on you. The immediate focus now does need to be on the continuity and sustainability of high quality primary care services in the town, and to that end we have two recommendations. The first is that the board is asked to agree that we find that there is no viable NHS capital solution to meet the increased capital requirement for the Teignmouth Health and Wellbeing Centre development, and that which we formally communicate that to the Torbay and South Devon Foundation Trust. Are we happy to approve that recommendation? Thank you. And we're also asked to agree that immediate action is required to provide support to the Channelview Medical Group to enable continuity of primary care services in Teignmouth, and we note that options in relation to this will be presented to the ICB board meeting in private this afternoon. Okay, thank you, everybody. Now we'll move on to the item on the governance improvement plan. Philippa, please. Thank you.
Thank you very much. So the governance improvement plan is being presented to the board for approval today, and it picks up on a number of the issues that have been discussed throughout the meeting. I think it follows having we've been undertaking work as the board for some time in relation to how best to ensure that the board is able to provide the leadership to the organisation that it needs to do, and thinking about forthcoming CQC Care Quality Commission assessments of the board in terms of its well-led framework. So we have had a number of private session and development session conversations in relation to how we assess ourselves in relation to the key lines of inquiry set out in the well-led framework, and they're set out in the report, so I won't go into them in detail. As a result of those sessions, we now have a improvement plan, which is included at the annex of the report, excuse me, which seeks to provide a rating for each of the key lines of inquiry and a number of actions that we believe need to be taken in order to improve the board and the organisation's performance in this space. We have sought to be realistic in terms of the timeframes that we put in terms of the actions, but obviously happy to discuss those. And I think the important thing to remember, as we've discussed already as part of this board, is that governance is about more than systems and processes. It's about the performance, the behaviours, the culture that underpin those as well. And so specifically talking to a number of the issues that we've already picked up this morning, but I think that's probably where I'll end it.
Thanks, Philippa. So can I open up the meeting to observations and questions for Philippa? I'm going to start with Sheena, then Judy, then Graham. Sheena.
Thanks, Philippa. This is a really interesting conversation that we had at a meeting. There's just a couple of your Chloes that I would wish to put at a higher priority and perhaps think a bit more imaginatively about the actions that need to be taken. So, in fact, you have already got appropriate information being processed as challenged and as high. But I think that the actions that probably need to be taken are against a context of limited capacity for that, and at the same time resource constraints. So I think this is so important that we start to understand what's going on and be able to explain it. You know, the old adage, you can't develop a solution until you really understand the problem. And I'm not actually convinced we're doing that as a system level, you know, across the silos well enough. So I'm just a little bit, quite like to revisit the actions there. And ditto on, is it number 8, the learning continuous improvement innovation. So whilst we might have a continuous improvement methodology, it's still, I think, only just being rolled out. And I think there are huge bits missing in terms of our understanding of innovation and the evidence base for innovation. Again, I'm not sure we've got the capacity to do that, but it would be brilliant if that could be raised as a priority, but also that we could start to talk through the actions, the necessary actions that would need to be taken to address those two areas.
Thanks, Sheena. What I think I'll do is just ask for the other comments before you then respond to all of them, if you could, Philippa. So, Judy, thank you.
Thanks. And I already wrote to Philippa and I thought this was a really good report, and it's great. It gives us really good steps to take. I'd like to suggest that there's an exec and a non-exec that are a sort of small subcommittee with Philippa on the board development issues. I know there are offers of support, there are a whole bunch of things in here, and it might be a good idea to just make sure that we act as a sounding board on the options that are available and the approaches we're going to take. I'll leave that for you to think about afterwards, not talk about now.
Thanks, Judy. Graham.
Thank you. So 5 out of the 8 Chloe's are already high, and I think, Sheena, you'd quite like to make it 6. And each has a number of actions, and we are already in quarter 2, so quite a lot of these are due quarter 3, so not that far away. What's our confidence of the deliverability of this, important though it is, in the context of an organisation that's undergoing restructuring?
Thank you, Graham. So, Philippa, over to you I'm sorry, Tandy. Sorry, I didn't see you.
Yeah, sorry. I think that's just a continuation of what you just asked. I don't know what, Chloe, this is, people, systems and partner engagement. There's an action in there about Health Watch and integrating and working with them. But again, that doesn't come in until quarter 3. But given the refresh of the annual plan that's coming, is there a chance that we can find ways of engaging them before that date, so we're not engaging after the thing we should have engaged in is past?
Thanks, Tandy. Philippa.
Thank you. So I think, thank you for comments and questions. I think with something like a governance improvement plan, there's always a challenge that everything is high priority, and I think it talks to the capacity issues that we've already been discussing. I think what we've done in pulling together the plan is seek to align to our annual plan priorities as well. So a number of the actions aligned to those annual plan priorities, which should provide the board with some assurance in terms of the deliverability of those. Obviously, there are other actions in there which are slightly more tactical that we think we can deliver a little bit more outside of that framework and probably a bit quicker. So I think that hopefully that addresses the capacity issue and the ability to deliver. I think there's a bit of a burning platform as well, though. So there are some of these things that we have to move forward on. So I think I would point to the board's membership stability, which I think is a big issue, but doesn't take a lot of resource to address. So I think we need to look at that. In terms of the partner engagement, I think it also talks to that point as well, because we've put a deadline for it doesn't mean we're not doing anything until we get to that deadline. So what we've tried to focus on is key deliverables. So we're looking at the deliverable of a memorandum of understanding or a document that articulates how we work together. But we continue to engage as all the way through as we get to that point. So it's the culmination of a piece of work which we will then deliver. So again, I think hopefully that also talks to Graham's point that whilst we're looking at deadlines in the document, that doesn't mean that we're not doing anything until we get there. I think on the points that Sheena raises around information and continuous learning, as this is a document which pulls together lots of different strands across the organisation, I think that's probably something we need to go away and talk about as an exec and see what the capacity to deliver is. But because it is within that context of the annual plan at this point, I think we need to be really careful about adding extra actions in that we may or may not be able to deliver. So I think that's probably one to take away. But I don't know, Steve, if you wanted to come in and add anything.
I guess I'd just make a general point, thanks, Philippa, which is, I guess governance improvement's never done, is it? So this is very much, for me, a first step to start to address some of those key issues, actually some of the things that have been referred to in relation to other papers. So I think it is ensuring that we take those initial steps, that we build the capacity and the capability, and then we can take further steps to become a sort of governance mature organisation, which will always be a receding target, I think, because we should always be setting our ambitions ever higher. I think the point around strategy and understanding the problem before you solve it is a really important one. Part of the work I want to do with the board shortly is to start to understand the nature of the strategic challenge that we face across NHS Devon, across the Devon system, so that we can start to think about what the possible solutions will be. We're at a point in time, again, driven in some ways, as you saw in some of the early reports, by the things that are just absolutely on our agenda, but we need to take a step back and think about what our whole strategy is. And I'm hoping the board will start to do that work as part of a board development and organisational development piece, linked to our values and behaviours, linked to our capacity and capability. So I take the point, Sheena, it's just going to take us a bit of time to do that well, I think, and to do it together. And on the point of a sounding board, Judy, I guess I think it's a great idea. I think we're relatively small as a group of INMs and execs. My gut feeling, I'm happy to debate it offline, is that we all run this together rather than as a subgroup, because I think it should be all of our business around the table and we all need to play a part in it. But I'm willing to be disabused of that if you disagree. But it just feels to me like this is so core to how we become a high-performing organisation that it's probably something we should all assent to.
Thank you, Steve. So just keeping an eye on the time, I'll bring in Graham and then I'll bring in Mark and then Donna. Great.
Just a quick comment. The alignment with the plan is great, but I've got a similar comment about the plan, which is the doability, given the number of objectives that's in that plan when we come to that agenda item.
Thanks, Graham. And Mark, please.
Yeah, thank you, Chair. Just a brief comment. Again, being conscious of the requirements of your statutory functions as an ICB, they are, if you go to the legislation, very high level and quite subjective. when you get your annual assurance letter from us, that will focus on your key statutory duties rather than an assessment of your performance, which is what the oversight framework does. So we just need to be careful that you don't get caught in the trap of delivering your statutory functions as an ICB. I think there's 17 of them. In some respects, it's a relatively easy exercise to do. I wouldn't. I would advise you to be really careful about that being a sort of key assessment, because it's more about your delivery of what you need to deliver for your population, as well as it's like a de minimis. The statutory requirements is a de minimis for the ICB. The clear vision and strategy in delivering that, and the leadership capability and capacity to deliver your vision is probably more important than your statutory functions in that sense. Although, of course, you have to deliver your statutory functions. So it's a bit clumsy way of saying just be careful that you don't end up hitting the target and missing the point of what you're set up to deliver.
Yeah, thanks, Mark. Philippa, do you want to just quickly respond to that?
Yeah, absolutely. Completely agree that we need to be thinking about more than just our statutory function, so we'll make sure we build that in as well.
Thank you. And hopefully the new oversight framework that will be issued in due course will also take that into account, because I think we're stuck with some fairly conflicting ways that we operate as NHS England as well, which we want to address.
Thanks, Mark. And final point on this to Donna, please.
Just to say, commend to Philip on the work you've been doing and getting to the stage to call out the need for this and to articulate steps. I suppose my question is resource. To expect if leadership capacity and capability is, first thing on this plan, then what is the resource and investment that's going to support that? And we do have other papers later on the agenda which recognise to get change and improvement does need investment at times, because to expect people to do more, or if there are capabilities there, it's not about the individuals, it's about skills and expertise at a time and place. So whether it's other partners bringing additional resource and leaning in, it doesn't have to be about money. I would like to see some recognition of the need that this organisation's not, in this systems leadership on their own. So what are we asking of our partners in terms of that? Capacity in terms of lots of ICBs across the country that will be ahead of us that can lean in and provide support. So it's not always monetary, but I do think we have to recognise, and it's been fantastic to have Alison's support in recent times, but we have to recognise that this will need additional skills, expertise and resource to help us drive this forward. So maybe that'll come at a later date, because I think this is a really good first step. But I think we have to have clarity on that and honesty that will be required in the scale of challenge that we face.
Thanks, Donna. Do you want to come back on that point, Philippa?
Yeah, and thank you, Donna. I think that's incredibly helpful. I think that for me, a lot of this is about how do we make sure that we develop the headspace to think about this, because what we need to be careful about is saying that this is a governance team issue and governance team have to deliver it. It's everybody's issue and everybody has to deliver it. So what's the nature of the resource support that you say? So obviously Steve has already mentioned that the organisational development work that we're doing, and I'd see a lot of that moving in there. We'll obviously see as we get towards the finalisation of our organisational change programme phase 2, the look of the resources across the organisation as well. But I think we can't underestimate ways of working, and I really value the point to think about how we look outside ourselves as well, how we look to our partners. So absolutely. So, for example, we are reaching out to local authority colleagues, particularly in relation to our integrated care partnership, and think about how that works. We are reaching out to our system colleagues to think about how we can work together better as leadership teams across the system. But we're also starting to reach out to our other ICB colleagues as well, and how we can work better across at a peninsular level as well. So I think it is absolutely resource, but it's also being mindful about thinking about things in a different way as well.
Thanks, Philippa. So I'm hearing widespread support for the governance improvement plan, and it is clear this will support the board in its role in ensuring the provision of high quality and sustainable care across the Devon health and care system. We're also hearing, I think, those tensions between the burning platform and the capacity issues and the resource issues, and so the board, I think, is asking the executive committee to take that forward and look at how we resolve those tensions between those issues. And we're asked to approve the proposed governance improvement plan for NHS Devon. Is the board happy to approve it? Thank you very much, everybody. And we stay with Philippa for the delegation of decision-making item. Thanks, Philippa.
Thank you. And this is obviously one of the items that's mentioned in the governance improvement plan. So this is again the start of a bigger piece of work. Where we start to clarify exactly the nature of the decisions that are reserved to our board and those which are delegated to the organisation. That's the scheme of reservation delegation that is proposed. We've also sought to propose some principles to be taken account of when exercising delegated authority. People need to be supported to ensure that if they are taking delegated decisions, that they're taking those in line with the strategic approach that's been agreed by the board. So that's the second part of the paper. And then really just to flag that this isn't the last piece of work in this space. I think that the second piece, and probably the more important piece, is the work on the operational scheme of delegation, which really dives down into the organisation and how these delegated authorities are operated. And we would aim to bring that back to the board in due course, and we're thinking in terms of September. I don't know, Steve, to add to anything.
Steve, please. Yeah.
I didn't want to jump in, but it was just to say, actually, based on a conversation that Kevin and I had with Donna this morning, I think there's something for us to think about in the arrangements currently in place, given our escalated status, about how triple lock interacts with this, so we can be clear about that. So I wonder whether we could just ask for a piece of work to overlay that against this scheme of delegation, albeit I would hope as a temporary addition. Thanks.
Thanks, that's a good point, Steve. Any questions for Philippa? Donna, please.
Can I just check that, you know, all this work that we've done, which is excellent, again, Philippa, so well done, have we benchmarked this against, because we've got journey of improvement here, so to what extent has this work been benchmarked against someone on the same journey as us, an ICB, or is it benchmarked in terms of a standard of outstanding practice? So I'm just interested in how we've benchmarked this and where it sits, just for that assurance, and the thinking behind it, Philippa, would be helpful.
Yes, so there is guidance out there in terms of how to construct a scheme of reservation delegation. However, it recognises that every ICB is different, and the ways in which ICBs which want to operate are different. And I think if we have looked at other ICB schemes of reservation, and they're all very different. I can confirm that. The ICB that we have particularly benchmarked again is the one that I have most experience with, which is NHS Sussex, which is not on the same improvement journey that NHS Devon is, but has got a good sense of stability in terms of its operating framework. I would envisage that we would see changes to this as we move through that improvement journey. I think hopefully that gives you the assurance you need.
Thanks, Philippa. Any other questions? Oh, Kate, thank you.
It's probably worth me saying for the other ICB in the room that we've appointed a new company secretary, so we'll be going through exactly the same process. And we will be making contact with Philippa, because I think our company secretaries will know each other.
So absolutely, we've already made contact, and we both worked on the scheme of reservation and delegation together at NHS Sussex.
Okay, thank you. So delegation of decision making, that the report provides the board with information about the work that's been undertaken to refresh the NHS Devon scheme of reservation and delegation. We're asked to approve the proposed revised scheme of reservation and delegation. Is the board happy to approve? Thank you. We're also asked to approve the proposed principles to be taken into account in the exercise of delegated authority, which is set out at paragraphs 10 and 11 of the report. Are we happy to approve that? Thank you. And the NHS Devon standing financial instructions and operational scheme of delegation are included in this pack for completion. And we're asked to note that no changes are being made at this point to these documents, but that further additional work is being undertaken on these documents. And we've heard that we'll explore whether or not the processes around the triple lock need to be reflected in those documents before we bring them back to the board. Is everybody happy to note that? Okay, thank you. So we're now moving on to the annual plan, and I'm going to ask Steve to take us into that. Thank you.
Thank you, Chair. I'll take the report as read for now, but there were a few comments I wanted to make, and actually they link to some of the comments that have been made around the table on in some other areas. So this is the first time we've tried to do this, and it is an attempt to try and get far more clarity about all of the work that the ICB is doing in relation to both the operating plan and those things that are focused on delivery of those actions linked to the NOV4 exit criteria, but also the wider joint forward plan commitments that we made as an organisation and the refresh that came to board earlier in the year. I would firstly characterise this again as a start of a process, and we do need to build on it in future years. You will see in there that we are bringing forward our processes for planning for 25-26, and we need to be clearer in that planning, because I think, to pick up particularly Graham's point earlier, we need to be clear about what the resourcing, the capacity and indeed the outcomes and impact are from some of these actions going forward. So whilst I recognise that this is not where it needs to be at the moment, it is certainly part of that improvement journey which we've referred to a couple of times today. In the way in which we are driving this forward within the organisation, we've refreshed and formalised our senior leadership forum. We're trying to think of a different name because we have too many forums and groups starting with S. But that is our internal, essentially our direct reports, our directors and deputy directors, which I chair. And we're using that meeting to firstly monitor performance against this plan. And there are a lot of actions in here. And I have been clear with everybody that they need to be honest, and it's a safe space to say where they think they won't be able to make progress on things, so that we can deal with those things. But everything I'm getting back so far is ambitious and a desire to make these things happen. That group will also be the place where I drive delivery of this across the organisation. And importantly, I think something which has been a challenge for the organisation in the past, because we've got all of the directorates around the table, it enables us to start in more depth working in a matrix way for each of the directorates to know what everybody's doing, and for people to both contribute and be part of it from across the organisation. And I've also asked them, as they're starting to think about future years, that we become a lot more crisp about what exactly it is we're going to do by when in relation to some of these things, because some of the objectives at the moment are perhaps difficult to measure. So I am intending, Chair, to bring updates on progress with this to every board meeting going forward, and we'll also, of course, bring the first cut of the 25-26 JFP elements of our annual plan for a discussion with board in October. And I'm keen at that point that we have an opportunity to discuss, perhaps in a development session, actually what are the capacity resourcing choices that we need to make to ensure that we come up with a plan next year that we can cut our cloth accordingly. Happy to take any questions.
Thank you, Steve. Can I bring in Kate first, please?
Thank you, Steve. I think the way this is laid out is brilliant. It's really transparent. So we will be stealing it when I go back to Cornwall. The other point I'd like to make is around we're going to call them commissioning intentions. They're population commissioning intentions, 25-26. But it would be great to share them between us, because I think there will be a commonality between the things that we need to do. And then linking back to the clinical reference groups, between us we could have quite a powerhouse that could be very exciting, which if we align with the Health Improvement Network, Health Innovation Network, we could be in a place where we do get some resource, but we get it through matrix cross-system working rather than employing people.
Yeah, if I can come back, yeah, great, Kate. Really keen to do that. And yeah, we talked the other day about we're going to do the same with commissioning intentions for next year. So I think the earlier we can have that discussion, the better, because there will be some real synergy there, I'm sure. But yeah, really looking forward to working with you on this.
Okay, so I think I had Graham, then Donna, then Frank, and then Mark.
Thank you. So I'm with Kate. I think the clarity is great to see. But these are objectives by directorate. Having spent years in places like GSK and GE Healthcare, I would never be allowed to get away with a plan that isn't resourced and has got some sort of time sequence to it. Now, maybe that's going to happen. But if you're asking me, can I sign this off as a plan? To me, it's not a plan. It's a set of laudable, sensible objectives. I've already made the comment, there's quite a lot of them, but the devil's going to be in the detail of the doability of it all. So at some point, I think we would need to see something appropriate for a board to give us the confidence of its achievability.
Yeah. So what I think I'll do, Steve, just because we're just because of the time, I think I'll bring in every comment and then ask you to, if you could record them and then respond in total. That would perhaps save us some time. So Donna next, please. Thank you.
Just like to commend everyone involved in the next step for us as an organisation. Particularly to see safeguarding improvement down there as a statutory responsibility of this board. You know, we've been calling for that for some time. Having a safe front door is an absolute expectation for all of us. So I absolutely welcome that. And also I think it's important to comment that the practice behind that is improving. And people like Penny and others involved in that, and Sue and Hannah, that we must note that the work they've been doing through a very difficult time to attend meetings on this, but it's great to see that back up in this plan and calling it out, particularly when our front door has been unsafe for a long time in Devon's area of responsibility, and to see that. So that is just fantastic to see that. In terms of the piece on children and young people, which I'm delighted to see that there's more balance in this board, that children and young people are a priority rather than just other parts of the service. Woohoo, I'm just going to say that at last. Yes, we recognise that children and young people are the future and that's where we need to have the balance. Can I just make a request, though, that I don't see anything about corporate parenting in here? We are all corporate parents. Our care leavers, children and adults are most vulnerable. And if we can possibly add that in as something we can get round the table, there are things we've talked about here before that we can do very quickly for those young people in terms of family farm and so on and so forth, but are making sure that we get those health assessments carried out in time. And there are things happening across England that we're not doing there. So I think it would be an omission not to have care leavers, especially when we're under commission. For children and young people in Devon, but also I think, we are corporate parents and we need to get that in there, but well done everyone, children and young people at last. I'm just going to be really positive and passionate about that because we need to talk about young people passionately.
Right, so just keep going around the people who've raised their hands, and Alison, I've noted you want to come in as well, but we've got Frank next, please.
Just one quick one. I found this incredibly helpful to realise who's going to be responsible for what. As an ICS, I hope we're going to publish this so people outside the system, because I often get asked by GPs, where does something happen, how does it happen, who's responsible, and where are decisions made. So I think it's probably worth it being published fully.
Thanks, Frank. Mark.
Thank you, Chair. So my observation is just about the ordering, bearing in mind all the comments that have been made, which I'm very supportive of, but particularly the points that Graham have made around this being a set of objectives. So it's really about mapping to the bullet points that you've put in the purpose at the beginning. So you've put at the bottom the integrated care strategy, whereas actually the partnership strategy is the driver for this, and the legal responsibilities of the ICB is to have due regard to that integrated care strategy. So that ought to be at the top of the bullet points. The 5-year forward plan is your response to that. And then the recovery plan and the operational plans with this set of objectives should all map to that single sort of purpose. So I just think it needs a bit of mapping and reordering to help the public, the board and everybody make sense of what you're trying to achieve with this particular plan.
Thanks, Mark. Let's move to Judy.
Like others, I think this is really good progress and it's great. I have one nervousness, and that is that when you create a document like this that is very clear and easy to read, there's a lot of shorthand in it, and we tend to sometimes pick up one target that is a target we have to meet without thinking about the consequences it might have on the rest of the system. So if I can use one example, and you know I will use a primary care example, number 64. Same-day general practice model. Same-day general practice is important for people who need urgent treatment. But at the moment, we're squeezing out continuity of care. And good general practice is actually about continuity of family care to prevent people accessing more specialist services. And so can we just be very careful as we use these targets and measures not to squeeze out other measures underneath in the detail that make sure we keep the services meeting patient need rather than our 10 top lists of measures?
Thanks, Judy. So I'm going to have Piers next, then Alison, then Sheena. Then we'll probably have to close the comments. So Piers first. Yes.
Thank you. I wanted to do the same that others have done. Really, just commend the work and what Steve said right at the beginning in his introduction in terms of the approach that's being taken. This is another green shoot. Genuinely, we didn't have this last year. Sitting behind this. This is a high-level plan, but sitting behind this, every director should have detailed plans with the specificity that we've indicated we need to see to measure, with the targets that are measurable, with timescales, all that level of detail. And in terms of resourcing, this is a prioritised plan. So every director should have signed this off to say this is what we can and will deliver over the next, what's remaining of the financial year. I was going to say 12 months, but that was optimistic. And so it is still challenging. Of course, it is in the context of all the things we've previously said. But I just wanted to say that in support of you, Steve, this is really important. And starting the cycle, as you mentioned in your introduction again, much earlier this year, well before we get to the start of the next financial year, will put us in an even better position then for the following financial year to deliver. Those are important points to note. Thank you.
Thanks, Piers. Alison.
Thanks, Chair. 2 points, if I may. So the first is, it might be helpful in the context of NOF4 for us to just do a bit of mapping so we're not duplicating. Because there are things in the operational plan, they're in the NOF4 improvement plan and vice versa, and you'd expect to see that. So an offer to help to do that, to avoid duplication. And the second thing is that, building on what Piers has just said, on the basis that there are plans and metrics that sit behind the objectives sitting with individual directors, just a question about how that will be monitored and reported on, and the performance against trajectories clear, and that visibility up to the board. I appreciate it's work in progress, but it would be helpful to understand that.
Thanks, Alison. A final point from Sheena, please.
Yeah, thanks. This has been incredibly helpful because I'm starting to understand a bit more what the ICB does. It's taken a while. Have we got plans to embed both process and outcome evaluation into all of these objectives? Because I suspect that you're going to probably make differential progress or cost different objectives, partly because of contextual pressures like NOF4, etc., but also because some things are more difficult to put in place than others. And it's really important that we are open to what works and what doesn't work, that we can act with agility to abandon what's not working and shift it around. And just like to know that we've got that sharp learning embedded in it. So I think I'm happy to talk to you about evaluation, but I'd really like to see some sort of clear evaluation embedded in that. As part of that, Judy's mentioned something where there might be a clash. We need to be open to where an objective might actually clash with another objective. So my example was actually improving patients' experience of choice at the point of referral, which is very motherhood and apple pie, and you can't argue against that. On the other hand, if you're trying to get efficiencies across the system and maybe funnel some patients here and some patients there, that one might have to be abandoned. We're firefighting here. The third one is we talked again before, these are still, because their objectives around directorates, they're quite siloed. So we sort of see primary care and we see community and children's and all of this sort of stuff, whereas actually what we need to be doing is thinking about a system. We need to be thinking about the relative mix of care from preventive, community, primary, acute, hopefully shifting left, reducing the call on the acutes. So I'm just wondering if sort of in next year we could start to think about how we shape our objectives and the way in which we assess our progress towards those objectives around whole system issues. And one way might be around kind of selecting clinical groups and doing it around the care model, you know, literally from prevention to death, and seeing how we're dealing with that. And then the final thing is there's nothing on digital in the community. Please can we have that at some point?
Thank you, Sheena. So, Steve, over to you.
Thanks for all the feedback. Actually, I'm going to make it one of my success targets for every meeting that I get a woohoo out of Donna. Thank you, Donna, for that. And it is certainly good to see, you know, we are looking at this as a balance. I'll pick off some of the individual issues, and then there's probably a few philosophical issues just to pick up. I think the corporate parenting, I saw Hannah nodding. I think, yeah, we will pick that up. It was probably fair to say it wasn't in our JFP or at least for this year it wasn't, and therefore we do need to think about how we pick that up in future iterations of the JFP, so it just becomes part of what we do. So happy to pick that up, Donna. Happy to publish it as well, Frank. I don't quite know how and in what way we're most effective, but I think partly about how we tell the story of what the ICB is for is the stuff that we are doing at the moment, so we will take that offline. And Mark, yeah, I take the point. I guess those were never meant to be a prioritised or ordered list. It was just a list of stuff, but we can certainly look at the order of that, and there is a logic actually, which is almost the reverse of what we put there, which might be helpful to change. The issue around the sort of where we think some of the things might cut across each other, or where the devil is in the detail of exactly how we do things. I think Judy's point. I do think when we start to look at our plans for next year, we as a board need to out those issues about actually what do we really mean here, and there's going to be a number of ways in which we can do that. One is through specifically looking at the JFP actions we want to take next year, and for the board to look at where the potential conflicts or overlaps are. I think it also picks up partly Sheena's point, but also for me there's an important point when we set our strategy going forward, and as I've mentioned earlier, I'm keen that we start to have that discussion now, that the board starts to think about what its principles are upon which the strategy should be based, and one of those principles may be that we want to ensure there is really strong continuity of care, for example, in all that we do, and that then guides how we go about doing some of these things. And there is also then a link into our board appetite, board risk appetite work, which is where are the red lines that the board don't want the organisation or the system to cross, which are very important and sort of sacrosanct to us, and that's an important part of our governance thinking going forward, which we need to pick up. Alison, on the mapping of the NOF4 stuff, I mean, for me, the construct of this is that the annual plan is everything and includes entirely all of the operating plan stuff. So the overlap should be it's sort of entirely inclusive within it. So in the end, we get to the point where the board is clear about everything that we're doing, whether it's in the operating plan or in the JFP, in one place. And I think as a few people mentioned, being clear about it, but also the risk around being siloed. The use of the Senior Leadership Forum is a first step towards trying to break down some of those silos. I would say, however, it would be really helpful for the board to know, and the way it's constructed at the moment, who you eyeball around the table on a particular issue. That's not to say it's entirely the CMO's responsibility, but who do you look at? And I've always had a sort of bit of a mantra that one executive should be taking leadership for objectives, not multiple, because then that becomes immediately confused. And I think on the monitoring and visibility at board, Alison, yeah, I think the intention is that we bring this back monthly, and there are a set of, it's a mixed bag, but a set of trajectories around some of them. You'll see by the way that some of them are expressed, actually they're almost impossible to measure. So another thing we need to do for next year is make sure that the objectives we set ourselves for next year, we can actually measure what it is that we're doing, and we have some kind of trajectory or success criteria against it. I think on the issue around evaluation, point, Sheena, that you made, the sort of process and outcome evaluation. I think the first thing to say, part of our culture work needs to be that our staff in particular feel safe to fail on some things, and it'll be different according to the different objectives, because some of these objectives are statutory and therefore, you know, we absolutely need to make sure we don't. But in others where they are big and ambitious and challenging, we need to know that it's okay to fail as long as we learn from that failure and then move on with it. One of the dangers of the kind of approach we've taken is that every objective looks equal, but some of them are more complicated than others, and in time we'll need to think about how we do that in a better way so we can sort of bring some of that out. But I am keen that we do become a learning organisation, and a learning system, that when things don't work, it isn't the roof doesn't come down on people, but we use the opportunity to think about actually what happened and why we should do it differently. And of course, we've had some examples today where we absolutely need to learn from previous things that haven't gone right. And on also on the issue of sort of the risk of siloing, what we need to do going forward, and part of the work I want to do with the board, is to ensure that we have a set of strategic objectives. It's our objectives, and therefore we should, at the board level, be able to be clear about the fact that these aren't silos. We may want to give them to individual execs to lead on, but these are things that we want to do across the board. And I think that focus on the patient is probably a really helpful one for most of these, to think about actually what is it we're trying to achieve, and then a number of objectives may fit underneath that, albeit individual directorates may be playing separate parts in it. So I think that's something we probably need to reflect on, Sheena. And then on the resourcing clarity, the sort of bit where we started with Graham, yeah, the conversation I've had with our senior leadership forum, I think, as I sort of alluded to at the beginning, is to measure their confidence in you that they can deliver on the things that they've said they can deliver. Some of the objectives did fall off as a result of that, and that was a judgment about capacity, capability. In the places where we needed the money, did we really have the money? I don't think we're quite there yet, and also I don't think we're at a place until we can get to the point where we've got consistent planning documentation where we can describe to the board what that whole resourcing piece should look like. But I'm hoping we'll be able to make progress from here so that we are absolutely clear when we sign up at the beginning of the year that we've got the people, the skills, the money, whatever else we need to be able to deliver. So bringing all of this sort of into around the big advantage of starting this process earlier, as Piers mentioned, is that we can start those discussions in October. We can start to guide our decision-making and our resource corralling in a way that we haven't been able to do this year. And I think that will then make next year a step change from where we are now. Hopefully I've dealt with every issue, but I may have missed something.
Well, thanks for that, Steve, and thanks to the ICB teams that have worked to develop this annual plan. I think it's a tremendous piece of work, so let's record the board. Thanks for that, and I'm hearing in the meeting today that we very much welcome this approach of having one plan for the organisation. I think it really does bring clarity to our priorities and timescales. I'm also welcoming the offer from Steve that we have a touch point with this at each board meeting in future so that we can get a sense of the progress against it. And I'm also welcoming Steve's offer to the board that we start some early work on the plans for 25-26. And I particularly noted the point that Sheena made around there are other ways to do this around whole system objectives, and I think that that's a conversation that we could have in this as we move into the following financial year. Having said all of that, we have some recommendations here. First of all, we're asked to approve the 24-25 annual plan. Is the board happy to do that? We're asked to approve the annual plan delivery approach described in the paper. That's referencing the collaboration and matrix working. If we're happy to do that. Sorry, Donna, yes.
Can we please note the omission of corporate parenting, or the addition of it just in the... Thanks very much.
Thank you for the reminder. We'll note the omission of corporate parenting. We're asked to acknowledge and agree the outlined next steps. Are we happy to do so? Thank you. And then finally, we're asked to note the list of objectives not currently included in the annual plan that require further consideration and assignment to chief officers. Those are outlined at Annex B. Are we happy to note that and hand it to the executive committee to determine how to progress those.
Can I just say, if Cornwall wishes to use this, it's £80 million to buy it off us?
We wouldn't dream of paying a penny less.
Thank you. On that note, I think it's time for a break. Can I suggest 15 minutes for the break and that we return to the meeting at midday? Thank you very much, everyone. Okay, thank you everyone. Thank you for getting back on time. Let's continue with the board meeting. And welcome to Sue Smart. Welcome, Sue. Good to have you here. And you're here to present the item on children and young people's services recovery. So over to you, please.
Thank you, Chair. I'll take the paper as read by all board members. So this paper is a follow-on from the May paper that board received with regards to children's services. We were asked to represent on the area of children's recovery, and board members will see in the paper that there is context in the back of the paper around the broader children's recovery. But we have focused in this paper on the autism recovery, particularly noting the importance of that in relation to our SEND improvement plans within the local areas and the targets that we're committed to within those inspection frameworks that we need to deliver on. The autism recovery aligns with our existing neurodiversity programme within the ICB, so that would be work that members may be familiar with, which forms part of our joint forward plan. But as part of this essentially sort of waiting list recovery, we will be looking to strengthen the actions within that plan to specifically deliver the targets, most notably the target to achieve the 52-week wait by April 2025, which is quite an ambitious and challenging target for us as a system. We're currently working through with finance colleagues how we identify that investment within the ICB that's been endorsed by the executive team, and we have a planning session tomorrow internally to start to work up the detail of the plan, which will be drafting throughout August and then signing off with system partners in in September to start to be able to implement that and to make progress against those targets. So I'm very happy to open up to any questions or comments that the board members may have.
Thanks very much, Sue. Any observations, questions for Sue? Frank?
Thank you. Steve might get his second woohoo because I find this equally important and I'm really delighted that it's happening. As a GP, it's not just the child, it's the siblings, it's the parents. It has massive impact. I just want to question a little bit about the detail of the numbers. The private sector are going to apparently get through about 850 patients on the list. We do need to think about what that means because I would suggest that the system and people in the system don't necessarily always accept private diagnoses one way or the other. So, if we are actually using private sector to do that, we do absolutely need to make sure the whole system is accepting of the outcomes. And it was about, I think, once they have taken those off, the assessments we're going to manage about 480 a year. It's still going to take quite a long time to get the numbers down. And the MDT approach is great. And it looks like it's going to manage 1,600 a year, but an MDT approach isn't necessarily a diagnosis. What it can't turn into is something that becomes a way of not dealing with the problem.
Thanks, Frank. Do you want to come back on that, Sue?
Yeah, thanks, Frank. And I think the implementation plan and that being signed off by all system partners is really important so that we strike the right balance between the transformation work and some of the other aspects that require investment, like the private work. I think there is an aspect of us moving into a more creative way of working through the MDT work, which isn't something that we've probably explored fully before. And that gives us opportunity that we might not have fully accessed before. So we may see those numbers being slightly different from what we've modelled, and that may allow us to kind of redesign what we then look to in terms of private assessments. So this is an iterative process that we're working through at the moment, and as we gather more intelligence about that, we need to adapt our plans as we move forward.
Thanks, Sue. So I've got Liz, Judy, Sheena and Tandy. I'll start with Liz, please. Thanks, Liz.
Thank you, Chair, and thank you, Sue. And again, I really welcome this report. This has been an area of focus for us from a provider perspective for a long period of time, and it's also good looking at the appendix that this is part of a broader approach to thinking about children's services that we know is going to be really important, and I know there's a plan to bring that up later on. The focus very much on creating a very differential approach to delivering care, I think, is welcomed. We know that workforce is one of our key issues, and what I would encourage us to do is just think about, as well as thinking about the transformation and different ways of doing things, that we look at the workforce strategy that sits behind it. We know from experience that sometimes if we move to private sector delivery, that all that happens is that we lose our staff from the NHS into private field, and therefore we don't actually build overall capacity. So absolutely right direction of travel, really welcomed. As providers, we need to work alongside you to make sure that we've got a very clear plan, make sure that workforce strategy is very much at the heart of it, please.
Thanks, Liz. Is there anything you want to come back on with that, Sue?
Yeah, I'm really happy to respond to that. Thank you, Liz. So that's one of the pieces of work that Piers and I have been discussing with Hannah and other colleagues in the workforce team to think about what that might mean. We've had some regional work that's happened around workforce that we can learn from, but I think we need to build up a really clear local plan for what that looks like for children's workforce. So I'm really grateful for the support that Piers' team has given us in that.
Thanks, Sue. Judy, please.
So I want to particularly endorse the point that Liz just made. We have actually tried the business of bringing in extra staff, giving extra money to bring in staff, and it just somehow seems that they keep moving out to a private sector. I wanted also to reinforce the point that this model of care has clearly not been working for quite a long time. So to urge pace, I know we said that last August when we had a discussion. So it would be helpful for us to understand if there are any blocks to the development of innovative ways of doing things. And I would like to say that, and I think there must be, I can see so many potential different models that can be used, so I'm glad you're doing the MDT experience. I don't think we should agree as a board to pay more per case than we need to pay, which is the implication of right to choose. I assume that's a national scheme or something. I lose track of all the titles, sorry, but we shouldn't in our financial position be endorsing a solution that costs more per case than an alternative that is possible.
Thanks, Judy. So I will ask Sue to respond to that, but I may just also ask Bill to come in on that point around right to choose and the payment for that. But Sue first.
Yeah, so completely agree with Judy's point around the need for pace, and I think the paper is implicit in saying that resources required to do some of this work, not all, but some of the work, and that has probably been one of our challenges historically. I think also the capacity and capability across not just the ICB but across the local health system to be able to really think about how do we recover children's services in a different way. There probably hasn't been that capability to date, but that's something that we continue to work with other partners on at this point.
Thanks, Sue. And Bill, Judy's point around, the board is being asked to pay more per patient under right to choose. Is there anything you can give us to inform our discussion on that?
Well, in principle, I agree with Judy. We shouldn't pay any more money than we need to, given the financial position. But I genuinely don't think we've got much choice. Certainly, in every one of the decisions that we've made in terms of spending, whether it's in the NHS or the private sector, we look at the least costly option and the one that's likely to be able to get service delivery. And we can have another look at that. And I'm happy to take that one away and do a further review, but I don't think we'll see a significant improvement, but very happy to do that and revert.
Thanks for that clarification, Bill. Let's move on to Sheena.
Thanks. I'm really pleased to see this paper because I absolutely agree with Frank. It's not just the kids, it's their families, but actually these are future adults. And if we don't get it right now, we're, increasing demands in the future. So I think it's really important. I like to see that benefit analysis. I still think this is quite siloed, despite the fact that we're talking about a kind of clinical MDT. I wonder, I understand that there are many clinical needs. I also think there are needs which are kind of social and financial and parenting and it might have a clinical label, but it's a lot more complicated than that. And I What I'm not seeing here is, well, first of all, no mention of education or the VCSE sector, which I know it's in the tables, but I'd like to explore how the different sectors can work together in different ways, rather than how different clinical people can work together in different ways. And also sort of really explore quite different approaches, like the compassionate generalist who can signpost people, who can, perhaps control demand a little bit, because this huge increase in demand for ADHD assessments is I don't think there's a clinical huge increase in ADHD. I think it's an awareness and it's a societal kind of thing, you know what I mean? So I think we need to contextualise the trends that we're looking at and say that there may be better ways of responding to them rather than slapping on a clinical label and introducing them to clinical teams. That's the one thing I was going to say. But also, I'm pleased to see that they're looking at kind of online assessment approaches or whatever. There are off-the-shelf online assessment approaches for autism and ADHD. It's a brilliant startup company in UCL, and I just wish again, we could be a little bit more savvy about our procurement of digital. So it's just I'm watching that space with great interest, because there is evidence to suggest that if you have a good online platform, you can speed up assessment without, reducing the quality. But I kind of wish we'd done that a little bit earlier.
Thanks, Sheena. Sue?
Yeah, so just to respond to that wider context, so I think particularly for this paper we were focused on the health service recovery as the responsibility of the ICB and what we needed to deliver. But again, I think for both Hannah and myself, and working with many colleagues across the system, we're working in each of the 3 local authority areas on a much greater footprint in terms of partnership working, so with education, with the council, with the parent care forums, to really understand the kind of range of needs and our contribution to that and how we work together. And I think particularly just drawing your attention to the Waiting Well programme within the paper, which is really about that much broader offer to children and their families, to make sure that both the digital offer, which I don't think we've got right yet either, and the other support to parents and families is available. So there is a wider range of work happening, but I think the focus here for this paper was on the health part.
Thanks, Sue. So I've got Tandy, Frank and Alison. So Tandy first, please. Thank you.
Yeah, can I just echo everybody to say how happy I am to see this piece of work. I think at the Quality Committee, we've just been throwing our hands in the air about, how big some of these figures are. Every time they're coming, they're even bigger, to the point where you think, are the figures even helpful or not helpful? But talking about the size of the figures, do we know how many of these children who are waiting end up converting to actual diagnosis of autism? Going back to Sheena's point, whether children are being put into that waiting list who may not actually get that diagnosis in the end, in which case they're actually wasting their time there. Is there a better, faster way of sort of at the gate end, move out the children that might not need to wait on this pathway and need to go somewhere else, and then just focus on the ones that really, might convert to a diagnosis? Do we know what percentage is converting at that point? The second point is, for me, I think the numbers are quite frustrating in some way, because it's so very easy to just get focused and sort of almost fixed on diagnosis. But I think what we really need is to start treating these children. So you've put something in there about Waiting Well. I'd like to know a bit more detail about what the Waiting Well package looks like, because I think that for the majority of these children to get in this pathway, somebody has noticed something to do with their language, their social interaction. Does it make more sense for us to sort of maybe just start treating those things, even if the diagnosis comes in later? My final point is about transition planning between children and adults. So on one of the other clinical policy engagement committee that I'm on, we were looking at a drug that is given to children with ADHD, but is not given to adults. So at the point of these children becoming adults, they find that they can't have that drug anymore because it's not been licensed for adults. Now, if we're having all of these children at this stage who, in 5, 6, 7 years' time, will all be a huge cohort of adults with ADHD or autism, what does that look like for the adult services? I think we need to have some long-term thinking as well on that.
Thanks, Tandy. Sue?
Thank you, Tandy. Chair, are you happy that Hannah responds to the first question that Tandy raised? Are you happy for Hannah to respond to the first question?
Yeah, I'm certainly. Sorry, so I couldn't quite hear that then. Yes, of course, Hannah.
So the conversion rate is high at the moment, so it's about 70 to 80%. But that does speak to what everybody is talking about in terms of the fact that we have set up a model for ourselves, not just in Devon, but in the country, where we are putting children and families through a diagnostic process to meet needs that may not actually require a diagnosis. So that's what everybody around the table is saying. And the principles of the wider neurodiversity change programme in partnership absolutely with education colleagues and with children's services in the local authorities and with our voluntary and community sector, because they're a really significant part of the support mechanism, is to identify needs, meet needs, and then understand which of those children need to then go through a diagnostic pathway. But what we've got at the moment is a whole bunch of children and families and a wider sector that is set up to respond to children having a diagnosis. And so it is going to take us some time to shift that culture. And we need to start somewhere. And we need to start with the children that have been waiting a really long time, thinking that at the point which they get their diagnosis, that will be the magic wand that unlocks how they can then live. And what we need to do is to start to change that. We need to give them the magic wand way downstream so that we are helping and supporting. And the Navigator key workers, which you'll see in the paper as part of the Waiting Well offer, are a really significant part of that, because that will be their job. It will be their job to be the first point of call, to work with those families. We know, for example, that for children, particularly for very young children, the differential diagnosis is really tricky between complex trauma or an actual brain disorder of some description, or a neurodevelopmental disorder. So the more time we can spend watching and waiting and providing help, so that when we do get to a diagnosis, if that is what a child and family wants, that diagnosis is really appropriate and can then support them for the rest of their lives. But we have to start somewhere, and we need to start with these children that have been waiting an awfully long time for as I say, that magic wand. And so that's why the focus of this paper is on that bit. Does that make sense?
Yes, it does. Thank you. And just maybe to add on to what you've just said, on the private... Just to sort of add into what you just said, on the point of involving the private sector, I mean, would you consider maybe involving the private sector on the treatment end as opposed to the diagnostic end? Would that make more difference? So in that sense, the children who've been waiting longer get faster help, whilst the ones who are waiting to get a diagnosis, and we know the diagnosis isn't really what they need is a treatment. Would that make sense?
We can definitely look at that. All of the models are under consideration. Mm-hmm. As I think GPs around the room will attest to, if we use the private sector for treatment, it does impact our shared care arrangements, so we have to be a little bit careful with that. But we can certainly look at that.
So do you want to answer Tandy's other points?
Yes, thank you, Chair. So just to respond to your other points, Tandy. So in terms of the Waiting Well package, we've mentioned a couple of aspects of that around digital, around parent support, peer support, but very happy to bring back further detail or to present that in another forum if that's acceptable. Transition absolutely is one of our priorities within the wider children's programme, and it's going to be really important as part of this work and much other work that we work really closely with mental health, learning disability, neurodiversity provider collaborative. So that's an important interface for us, and that we make sure that we work closely across the children's pathway as they transition into the adults and plan at the appropriate stages for that.
Thank you.
So there are a lot of people wanting to bring in questions. So just in terms of time, I'm just going to ask if everyone could ask their questions succinctly. So I think my list is Donna, Frank, Alison, Bill, Alex and Steve. So we'll start with Donna, please.
I just think the first thing is linked to a previous paper this morning. You know, we've let people down here. When you look at Annex 2, this is serious failings across the system. And one of the items are these waiting lists. So I do think there's something about how we communicate to families that we recognise that we let them down and we're taking action to recover this. So I'll welcome the word recovery. For a question in terms of point of clarification, then paragraph 26 sets out a financial requirement to improve this for this year and then into next year, but it's just short of £1 million. But when we go to paragraph 32, we get limited assurance on delivery. I just don't think that's acceptable, and it's about how we develop as a board in this place. But I would expect that we come forward to say we're going to do something and we've identified the funding to do it, because we have met with the DFE jointly, NHS and local government, and we've had our targets and send amended to recognise that there are key milestones we need to make. So we are under commission to make these milestones. We are under priority actions and notice here. That means that's unacceptable in terms of not just a challenge in the system, but here in our system we are underperforming compared to everyone else. So I think it's important. I'm just concerned that with limited assurance, how I had in the meeting jointly with the DFE to get our milestone targets changed, we agreed that we would report back, NHS England were in the meeting, and I gave the assurance that if I did not think that we could deliver that we'd recall a meeting with NHS England to discuss that, because we've signed up to targets, and if we don't have the assurance of the ability to deliver those, then I have a responsibility to go back to the DFE under a statement notice to say this is not going to happen and we need to have further conversations. So whether it takes out with the board or not, but we gave a time scale of that to the end of this month. But I do think we need clarity, and to me those two paragraphs don't give us clarity on how we're going to deliver this. And I accept that it's maybe a different way of doing things, but I'm glad to see that at least we're calling it out here and noting that this is what it requires to do this work. But we need to find this money, or quite simply, in partnership, we need to go back to DFE and say it's not deliverable, because then I think we wouldn't be accepted to have those changed targets in place for the year ahead.
So that's really helpful, Don. If you can bear with us, what I'd like to do with that is to ask Steve to respond to that in his closing comments, if that's okay with you as well. So Frank.
Thank you. I think we should regard this as an invest to save. Children with neurodiversity do not just have neurodiversity. Many of them are depressed, anxious, all the rest of it. Depressed 14-year-olds, 50% of them end up being non-productive adults who are supported by the system for the rest of their lives. So the longer we delay in helping them, the greater the problem we are creating for the state in terms of costs. So yes, there's big figures involved in investing in this, but it's really, really important. The other thing is the magic wand or the golden key. Unfortunately, the whole system around them still requires a diagnosis, and we will have to do an awful lot of cultural change on that. And that, you know, so the MDT approach is absolutely the right thing, putting in help in advance, understanding that they're not just on a neurodiversity waiting list. They do have depression at the same time, and they should have that dealt with rather than being told they've got to wait for their neurodiversity. So if we don't improve this, not only are we letting them down, but we are creating massive cost for the rest of their lives. And Sheena mentioned it, they turn into adults who just do not manage to be productive. And the level of employment for these people is very low. Is that because we haven't managed them well enough and given them the opportunity?
Thanks, Frank. And I think that works well leading on from Donna's point. So again, I will ask Steve to pick that up in his closing statements, if that's okay with you. Bill, I think you lowered your hand, but please do put it back up if you want to, but I'll move on to Alex now.
Thank you, Kevin. Actually, Frank said a lot of what I was going to say, but I was going to talk in support of what Hannah was saying earlier. Actually, and what Frank was saying, the diagnosis does seem to unlock things, but we need to be we just need to be supporting these children and their families before the diagnosis. And in my experience, and I don't know whether it's the same for Frank, but around ADHD, a lot of these children in particular will start taking the medications that are prescribed, and then when they become teenagers, they stop taking them for all sorts of reasons and don't take them into adulthood. So I don't think the medication is the answer. It's about all the support around them and their family.
Thanks, Alex. And Alison.
Sorry, if I could just preface this by saying that I absolutely agree with everything that's been said, and Hannah, you answered one of the fundamental questions for me. Just a very practical one. Is the in-year investment included within the plan? Because if it isn't, then there needs to be a solution to that.
Thanks, Alison. And I think Steve will pick up that point as well. So over to you, Steve.
Yeah, thank you. I think the first thing to say and to reiterate is what many people have said around the table. This has been an unacceptable level of service for children in the area, and something that we absolutely need to recover from. And this paper, whilst recognising the wider points, which are all really valid and really important, this paper is simply about recovery at this stage of something which we should never have got into in the first place. I do think on that wider piece, as I alluded to, the discussion that we need to have as a board about our strategy absolutely needs to include a discussion around our future ambitions for children and young people services across the patch. And I think, Hannah, just looking you in the eye, I think there's a significant amount of investment that might be needed in the future, and of course that's very difficult in our current environment. But that's something, again, the board, I think, needs to understand, and we need to make some choices about going forward. But this is an important part of our work. I think the issue around money, if I can just nail that, I think Donna and Alison clearly raised it. We need to acknowledge, picking up Alison's point, this was not in our plan this year. And I think there are lessons that we need to learn about that. What we did is we absolutely signed up, I would view in sort of corporate blood, to the fact that we were going to get these waiting times down whilst we then did the wider improvement work and investment work around children and young people services. So as I sit here today, while it says limited assurance, as difficult as this is for the ICB, we have made commitments that, as far as I'm concerned, we need to find a way of financing. So it's a how we do, not whether we do at this point. So I wouldn't want to go back to the DfE or NHS England and say we're now trying to back away from that. We've just got to find a way of squaring the circle in which we find ourselves. So hopefully that reassures that we've made commitments. We should have done it in a different way, and we do need to learn about how we operate our governance systems internally to ensure that when we do make those commitments, we are clear before we make them about the people, the money, and any other things that we need to sign up to. But we will get better at that as we move forward. I think Frank's point, it is really heartening to hear the Secretary of State himself talk about the NHS as an economic growth department, and I think this is a very granular example of the things that if we invest in the right areas, actually it does help the wider economy, and that's a debate and a challenge I think we should be rising to. There is so much we can do to improve the economic outlook and the inequalities we see through the way that we do business and the thing that we focus on. Again, I'm keen that forms part of our sort of strategic principles going forward, and we do in all of this, and Hannah said across the country. Actually, my experience in Wales is this is no different in Wales. We have a model which is largely biomedical and is looking at trying to diagnose and fix something, when actually what we have is a social medical issue, and we need to think about services that wrap around that. However, we do find ourselves with a target that we must hit because we said we're going to hit it. So we're going to be an organisation that does what we say we're going to do. And the final point I make, with your permission, Chair, I think there would be an opportunity maybe to take this into a committee so that we can look at with IMs and others some of the things around waiting well. There are some really good things going on in there. It may not be that we can do it in a full board meeting, but I think we could do a bit of a deep dive around some of this stuff and have some of those discussions around digital, some of the stuff that Tandy raised, to really test ourselves and whether we're being creative in this. But I do think when we come back in the autumn and we're starting to think about next year, children and young people absolutely need to be in our thinking alongside everything else. And I don't promise that's going to be an easy discussion for us to have, because we won't have enough resources to do anything, but we need to do everything rather. But we do need to have that discussion as a board so we can guide the organisation into its planning road. Judy looked confused at me, which is always a worry.
Can I just ask, I'm not clear whether you're saying we can fund what is requested this year or we can't fund what's requested this year. Apologies.
Sorry, yeah, I'm conflating two issues, so thank you. Yeah, we will have to find the funding this year for what's committed to in this plan. What I was talking about is there's a wider need for investment in children and young people services, which we need to debate alongside all of our other priorities.
Thanks for that confirmation, Steve. And we're suggesting, are we, that we take this into Quality and Patient Experience Committee for some from deeper work, and Tandy's nodding, so we'll note that as well. And final comment on this from Bill, please.
Thank you. So, not to contradict anything that's been said, and not to dampen the mood, but in terms of the questions that were being asked, from a financial perspective, all things being equal, we will need to find either £960,000 worth of additional savings or deprioritise an investment commitment that we've made in order to do this. Now, that doesn't mean to say that we can't do that and are not committed to do that, but as things stand at the moment, I think the board needs to be aware this is not factored into our current plan. And I think that's the reason why factually it said limited assurance in the report. And as Steve said, we need to find that, but I don't want the board to be under the illusion that we found those resources yet. That's something else that we need to add to the pressures that were already discussed.
Thanks, Bill. Thanks for that clarification. And thank you to Sue and your team. I mean, the point's been made in this meeting, isn't it, that you know these waiting times here are also letting people down. There's a human story at the underneath every one of these numbers in the waiting numbers, isn't there? So, thanks very much for bringing the report to the board and focusing our attention on this really important issue. We're asked to note the significant risks that are outlined in the report relating to the SEND service provision to children and young people within the One Devon integrated care system. Are we happy to note that? The board is asked to take assurance from the development of system improvement plans which will enable system partners, including NHS Devon, to deliver the statutory and regulatory obligations in respect of these services. Are we happy to take assurance from that? And then finally, we're asked to note the limited assurance on the deliverability of the improvement plans and recovery actions, and that these are dependent on identification of the sources of funding. So we're also asking, as a board, we're asking the executive to identify those resource requirements referenced in the report, and note that that's estimated at 960,000 for this financial year, and noting Bill's point that we need to have additional cost savings elsewhere, or some other way of resourcing that 960,000, as it wasn't in the plan that we signed off a couple of months ago. And we've also agreed that we will take some more detailed deep diving into the Quality and Patient Experience Committee. Okay, thank you very much for that, everyone. We now move on to the local maternity and neonatal system stocktake. We have Hannah Polisi here with us. Over to you, Hannah.
Thank you, Chair. So this paper has been presented to the board to provide a stocktake of maternity services, the improvement and compliance agenda that sits around maternity services, and the responsibilities of the ICB within that. And this is all within the context of a sustained increased focus on maternity services at a national level, which we haven't seen any kind of dip in for the last 5 years. The paper's presented in 3 sections. The first is an overview of the compliance and surveillance framework, both for the ICB and for the trust boards. The second is the Devon status against that compliance framework. We haven't included Cornwall in this, comes on to the Cornwall bit in a second, but and where we are achieving against that framework, some of which are numerical targets and some of which are deliverables. And then the third section is about the wider transformation agenda, a strengthened alignment of a whole systems approach. and how this fits with some of the broader programmes of work that we've got happening within the system. So the Peninsular Acute Sustainability Review for one of them. I'm not going to dive into any of the detail in the paper, but I'm very happy to take questions.
Thanks, Hannah. So let's open up the meeting to questions for Hannah, and I have Sheena and then Graham.
Thank you very much. This is a really interesting area. It's my ignorance, actually. I note with great joy that you sort of say that addressing health inequalities is a core element of maternity transformation. But I'm not getting a sense of geographical inequalities in this paper. I kind of get the sense of deprivation and stuff like that. But I have a feeling, and I don't know, that there may be slightly different offers for pregnant women and new mothers or new parents in different parts of the county. So I think, for example, North Devon does offer a visit at home and a post-visits at home, whereas I have a feeling the rest of RD&E doesn't. But that's really, really important in terms of accessibility, particularly in rural areas, but also in terms of the potential cost-effectiveness of the offer. Because if you have someone then going into hospital postnatal because they haven't managed to establish their breastfeeding, or something's a bit worrying, it's quite expensive. So are we monitoring that? Do we know about that? Are we collecting the data?
So we do know that there's variable offers, and certainly in response to the pandemic, one of the things that we've started to look at more recently is the level of face-to-face interaction with women and families, and the amount of home visiting as opposed to bringing people to outpatient services. It has been challenging for maternity services to revert following the pandemic to a more peripatetic offer, and you're right, there is variation, but yes, we are aware of it, and yes, it is a very live conversation within the maternity service system.
Thank you, Hannah. Graham.
Thank you. Yes, a few specific questions, if I may. You make some reference to workforce, as I know at RCM has been going on for years about the shortage of midwife capacity. So is that really something we can address, or is it going to be a national problem that we can't address? I see reference to CQC and inaccuracies. They do have a process by which you can sort out factual inaccuracies. I'm slightly surprised to see that, so I'd like to know whether that really is material in this paper or not. And then my last 2 points relate to the conclusions we're being asked to. I'm not quite sure when you're noting the commitment of BI, is that them committing, who's committing? And also in that conclusion, you're asking us to note the integration with Cornwall, and I see reference to it, but I don't see anything that explains the benefits or process, and the governance chart in Appendix 4 doesn't reference it. So just a few points there, please. Thank you.
Thank you, Graham. Hannah?
So there's an awful lot of work going on around workforce, both with the trusts and across the system. There's been significant recruitment and retention programmes delivered by each of the maternity units, and that's had some real benefits. In fact, I know Liz is in the room, but the Torbay recruitment and retention programme was showcased actually at a national level because of the findings from the work, which is really significant. There's also been a programme of international recruitment. It is against a national challenge, but actually, considering some of the other workforce issues that we have in the peninsula, for midwifery, we are doing okay. Obstetrics is a bit more challenging. And that's part of the PASP programme in terms of gynae and obstetrics. The CQC factual inaccuracies, I think the CQC in terms of its latest round of maternity inspections has been particularly focused on some specific issues, which if you apply them generically across any size of unit and any size of context, is difficult to manage. One example of that would be theatre capacity and spare theatre capacity. Apologies if I don't think inaccuracy is quite the right term. Actually, it's more about proportionality, I think, and so apologies for that. And the merger with Cornwall and the Isles of Scilly is a very new thing. We haven't even got together at a director or executive level to have those discussions yet. But it was there are significant benefits, especially given that the Cornwall system is a one maternity unit, local maternity system, so should add benefits both to Cornwall from being part of a bigger system and having that peer support and challenge, but also for us because there is some really good things going on in Cornwall which we will be able to learn from. Cornwall actually have the kind of national example of a maternity and neonatal voices partnership, which everybody looks to. So benefits all round.
Thanks, Hannah. And John, please.
And Chair, just a quick note on CQC issues. I'm sure many will know that they've had significant infrastructure challenges in recent months, and particular in terms of their portal, and they are behind on report confirmation and factual accuracy updates as well. So it's just to note we are experiencing that. We're hoping that that's going to be resolved through the year.
Thank you, John. So I think I've got Kate, Alison, and then Frank. Kate.
Hi, it's just a quick point for me. So we are very supportive of bringing the LMNSs together for benchmarking, because having one delivery suite is great, but we'd like to benchmark it against others. But also we're users of Plymouth for local births, but also for specialised services. So we've got a big interest in the Plymouth service. It's probably worth saying that we were inadequate for maternity 7 years ago with 2 Section 29A warning notices in succession, which was a shameful time for our CHT. Our service is amazing. So, and all the second theatre, continuity, split rotors, we did those years ago. So painful processes, but great services on the other side of them. So it'd be great to work together.
Thanks, Kate. So Alison, please. Thanks.
Thank you. There is a national programme which is almost like an RSP equivalent for maternity services, which is the Maternity Services Safety Programme, MSSP. And any system and organisation that is in RSP is automatically considered for MSSP support. So all of the trusts in Devon are currently going through the process of onboarding in the MSSP process. What that does do is provide the external scrutiny and support to develop a very robust maternity services improvement plan for the organisation. So I would imagine probably by the end of the calendar year, there will be a maternity services improvement plan for each of the acute trusts. So Hannah and I were having a conversation yesterday about the best place to lodge that in the ICB, so there is absolute oversight of the delivery of that. The slight word of caution I will put on that is that none of those plans that I've ever seen come without a price tag, because there is likely to be a number of recommendations which are going to require investment. So the sooner those are identified, they will need to be factored into future years' financial planning. But they may also be a catalyst for more integrated approaches to provision across the whole of the peninsula, because meeting the Ockenden compliance requirements on an organisational footprint is going to become increasingly difficult. Even if the money was there, the skills and the support that would be needed is not. So I would have thought probably by early in the calendar year, Hannah, there would be some visibility of, or the ability to bring some of that back to the board, so there's greater visibility of the opportunities that brings.
Thanks, Alison. I'm going to bring in Frank, and then I'll bring in Steve, who I would like to just respond to some of those things that Alison has just said, please. But Frank first.
Thank you. Obviously, this is an incredibly important area, and any service is built on your staff. I think we all have to recognise that this is a high-risk area for the staff and the patients. There's 2 young lives at stake at any one time. Long time ago, but I've spent 6 months on a paediatric intensive care unit. I've spent 6 months doing obstetrics. I've done an awful lot of anaesthetics. Things change very, very quickly. If somebody has an incident at work, we need to have systems that support those people to try and keep them at work, because we cannot lose highly trained people over certain incidents. I mean, clearly, if it's incompetence, that's a different issue, but delivering a baby is not a safe thing. There are 500,000 deaths a year across the world. So we just need to recognise for the staff, it's really high pressured a lot of the time.
Okay, thanks, Reg. So I am just going to let Kate in, and then I'll bring Steve in, and then a final word to Hannah if there's anything you want to pick up from the conversation we've had at the meeting. Kate.
So just in case we've got members of the public listening, so we have berths on the Isles of Scilly, which is 25 miles off the mainland, with search and rescue support if there is a problem at or around the time of birth. So and we've got lots of birthing centres around Cornwall where women can choose with low-risk births to have their babies in non-high-tech places. So I think it's a really careful balance between the in the hospital complex births where, and when things go wrong anywhere, they go wrong fast. But I just wanted to be really clear, it's around choice, and some women choose different places of birthing, and our role is to support them and our people in doing that, and just in case anybody's listening.
Thanks for that, Kate. That's important. So, Steve.
Yeah, it was only just a couple of issues. I think on the specific point around peninsular work, and we've got the opportunity tomorrow, Kate, with our strategic partnership meeting to maybe bring this into the terms of reference. I don't know what that might look like, but it might be helpful just so we've got a strategic overview between the 2 organisations. It just seems like an opportunity, my first one at least. I think the issue that Alison raised around the MSSP, yeah, I think it is something we need to be cognizant of, particularly in terms of the potential investment requirements. I think we just need to think about timings of that. It may not be possible, but if the board is going to start to look at the overall investment requirements into next year and beyond, the more we can do to preempt or estimate what that might look like earlier than December, I think Alison mentioned, that will make it easier for us to be able to put some adequate plans in place to address. But I also think through Liz and the PASP, the opportunities around maternity services that come out of that is something which we need to ensure that both the board understands and is part of our forward planning as well. So yeah, a lot going on in this space, and again, I think it's an area that we can, as a board, probably need to attend to more in the future.
Thank you, Steve. And Hannah, just the opportunity for you to anything that you want to take from the meeting, or anything that you want to give to the meeting.
Just to say that in terms of the work to merge Cornwall and the Isles of Scilly, we've begun to have conversations with peers in the commissioning organisation and within the trusts as well, and we would be happy to bring back a proposed plan for how we progress with that work, so that the board has oversight of that, and that the thing that I didn't mention in my introduction is the I sort of touched on it, but the overarching kind of compliance and assurance requirement for maternity is significantly higher than for some of our other areas, with very specific responsibilities for the ICB, and I think that's part of what we just need the board to understand today, and apologies for not bringing that out in my introduction.
Thank you, Hannah, and thanks to you and your team for this report. So thanks for all the work that's gone into it. So on the local maternity and neonatal systems stocktake, we're asked to note the Devon ambition for maternity and neonates in the context of the national and local strategy and the current position and challenges within One Devon integrated care system in relation to the key national safety ambitions and strategy. Is the board happy to note that? We're also asked to take assurance from the arrangements that have been made to enable NHS Devon responsibilities to be discharged through the LMNS for key monitoring and reporting, and the strengthened governance and oversight which will result from the new LMNS structure following phase 2 of the NHS Devon organisational change programme. Are we happy to take assurance from that? Thank you. We're asked to note the commitment of sufficient business intelligence resource to the delivery of a maternity systems dashboard. Graham, do you want to just come in on that again?
I'd just like clarification about who's making that commitment, please.
Can we have clarification on that commitment?
Yes, apologies, I didn't answer that question. The ICB.
The ICB? Yeah. So is the ICB happy to commit to sufficient business intelligence resource to the delivery of a maternity systems dashboard? So the Chief Executive is acknowledging that.
I feel yes is the right answer there.
And we're asked to note the proposals for integration of the LMNSs for the integrated care systems of Devon and Cornwall in the Isles of Scilly.
With the addition of proposal, yes.
Sorry, Graham.
With the addition of proposal, because it's
sorry, yes,
still got a journey.
Yeah, yeah. Did I not say that? The proposals, yeah. Thank you. Thanks, Hannah, and thank you to everyone for the contributions to that discussion. We're on to the quality report, and John, over to you, please.
Thanks very much, Chair. Good afternoon, colleagues. Presenting this report on behalf of Penny Smith, our Chief Nursing Officer, today. I take the paper as mainly read. There's a few points I'd like to bring your attention to. We can give good board assurance now, thankfully, that the implementation of the National Patient Safety Framework is going well. All our main NHS providers in the county are now working and submitting data on that. Sadly, with that implementation, as expected, we have limited assurance in terms of our access at ICB level to good quality data. There are national and regional programmes addressing that, and as we start to use the data practically as an ICB, it does give us better opportunity to improve that. There is also limited assurance in that space with the rollout across primary care, but again, we've got work that's seeking to address that, and also there are emerging national and regional programmes to pick that up. So that's patient safety. Some other good news, which I know most members will be aware of, is that the recent cryptosporidium outbreak in the Brixham area has now been officially closed down with all boil notices lifted. Really good work from primary care and also hospital services there in managing the impacts onto local NHS systems, which were thankfully minimal, notwithstanding the impact for individuals affected, of course, in the area. There will be learning and a follow-up event led by public health colleagues on that matter that we'll report on in future reports. The rest of the report gives summaries and updates on our areas of challenge from a quality and experience and effectiveness perspective. Particular attention remains in terms of Derriford Hospital and urgent care pathways there, and we also note challenges across the system with particular attention and support on children's and young persons services and mental health services as well. Really happy to take questions on that, and just wanted to conclude, Chair, by noting that the paper in this report is very much a work in progress, and we're continuing to develop that, and board members will see changes in subsequent versions in the coming months. I'll stop there.
Thank you, John. Judy.
Thank you very much, John. And I just wanted to praise Penny, you and the team, because I was around when Sarah was putting together the beginnings of doing a good quality report. Can I just double check? I mean, it's really helpful to have it here, but I'm assuming, Tandy, that your Quality and Patient Experience Committee gets this and discusses it in detail. So in a sense, for us, it's very helpful to read, but I was just double checking there was another committee going through it in detail.
Thanks, Judy. And Graham.
So first, yes, thanks. I think this, to me, this is the first time I've really seen it to this level of granularity, so it's brilliant to see it. That's the first thing. Very specific question, very, very specific question. Page 227, fatal incidents, DPT. More than 50% of all unexpected or fatal physical harm in DPT. Is that a cause of concern? Is that real?
No, it's not.
I know it's mental health, but
we have provided some narrative in that.
Yeah,
that data
really explain it.
is developmental data. Unfortunately, in terms of unexpected harm, that is the area of practice where we see it most. Through using the data and our conversations with DPT, we are assured that it's not outside of previous data reports or norms, and there is a unfortunate amount of data quality at play there as well that we are working through with our providers.
Okay, it's just that Livewell doesn't have the same sort of scale,
no.
which I thought it might have done, given that they both provide
one of the,
similar.
The silver linings of the cloud of the data quality issue, Graham, is that it's pushing us to have really good conversations with providers and look at how they're reporting their data and looking for standardisation across the county. But from a patient safety and well-being, from a population impact, we're not seeing DPT reporting numbers outside of their usual numbers.
On that point, Graham, Frank and I were having a conversation yesterday evening and this morning on that, and we thought perhaps this might be something that the Quality and Patient Experience Committee might just take and just seek some further assurance around that point. Do you want to say anything on that, Frank?
Yes, I mean, we did pick it up. This data, the LFPSC data, is new. The whole system has changed. Some of the providers are using it fully, some of them aren't yet. And what it will throw up might be spurious, or it might be very real, it might be quite different. Until we can look into it a bit further, we can't be certain, but it has been acknowledged, and we will do so.
Thanks, Frank. So I'll bring in Kate and then Sheena.
There could be a source of triangulation for DPT, couldn't there, because of the forensic provider collaborative and the fact that NHS England is responsible for the quality metrics associated with specialised services. So that would give some early assurance as to, because 23 in a month does look like a significant outlier. I'll just offer that for...
Thanks for that, Kate. We'll pick that up and have a look at it. And final point on this to Sheena, please.
Yeah, can I pick up the data question? Because you said right at the very beginning that kind of in a way lack of BI capacity was, unless I misread what you were saying, was sort of holding...
I didn't say about BI capacity.
Oh, sorry, I thought you were saying about
I've
data.
got BI capacity challenges as well.
Yes.
It's the level of data that ICBs have access to from the LFPSE system, which is the Learning from Patient Safety Event system, all the data uploads that go into the national system. So it's about the level of access that we have to that and then the quality of that data.
Can that be addressed?
It's a maturing system is the best way to describe it. So as it develops and providers get more comfortable and accurate with their data entry, and the levels of access are then developed by the national team. So it is getting better. 3 months ago, we wouldn't have been able to really show you any numbers. Now we can start to show you numbers, and that's maturing.
But there's also other sources of data. So my question really is that we talk about the providers and their data, but for quite a lot, I mean, say let's take end-of-life care, which I've suddenly got a real obsession about. I hope I'm not getting any insights about what's going on with me. But I mean, you've got a whole range of different services supporting this. You've probably got real variation across the county in terms of the numbers of people who can die in a hospice, or the numbers of people who unfortunately go into hospital, or et cetera, et cetera. There are data out there in terms of place of death, and some, are we triangulating that accurately in the...
Very much so. Good. And that's been one of the benefits of working with the LFPSE data, is it drives those conversations, so we can triangulate it with the number of DATEX reports that we get in, what we're hearing from our providers, and it gives a good sort of forum to have those helpful discussions.
Excellent. That's very reassuring. Thank you.
Thank you, Sheena, and thank you, John. And John, I know you say the report's a work in progress, but the board really does appreciate having this report at the meeting, and so thank you for all the work that goes into it. I think it makes a real difference to the board oversight on quality issues. So thank you for that. We're asked to take assurance from the content of the report, and the point that Judy made earlier. Of course, this report has been considered in detail at the Quality and Patient Experience Committee. Are we happy to take assurance from the report? Thank you. I've got an eye on the time here, so for the remaining items on the agenda, I just want to just bring to presenters' attention that we need to get some pace in order to finish the meeting by 1:30. The next two items on the agenda, Bill, are the finance reports. These have been considered in detail at the Finance and Performance Committee earlier in the month. Is there anything that you want to draw to the attention of the board from these reports?
Thanks, Chair. It's not often I get asked to speak faster, but I'll do my best. Yeah, just a couple of points. You'll see the two reports. One is the ICB position, the other is the position across the ICS. I spoke earlier about the month 3 position. This is the position as at month 2. It shows the plan that we signed off with NHS England. It indicates the fact that the initial plan that we submitted was £85.3 million deficit, and after discussion with NHS England regionally and nationally, that was amended to an £80 million deficit. That does put £5.3 million of additional pressure into the plan that we are delivering. As at month 2 and again at month 3, we are on plan, but as I said earlier in the discussion today, our plan is quite heavily back-ended, so that as we go into quarter 2 and then quarter 3 and quarter 4, the requirement in each month in terms of the level of SIP delivery increases, and as a consequence of that, the risk will increase. Included in the plans are a detailed articulation of the risks and mitigations, and also an indication of where we are with the cost improvement programme and where we've identified those, where they're still to be identified, where there are opportunities, and also a risk rating that goes alongside those. We continue to focus on and redouble our efforts to deliver savings. The board can take assurance from the position to date, but as I said earlier in the discussion, we continue to be in ongoing dialogue with NHS England, particularly regionally, and I've had detailed conversations with the Regional Director of Finance in terms of what happens with our position at month 4, what further discussion might be likely as a consequence of that if the plan does not improve, or delivery against the plan does not improve, and what that would mean. Board members may be aware that nationally a number of healthcare systems have been rated as having high-risk plans. We are not in the top level of risk at this point in time, but quite clearly failure to deliver in ongoing months would likely lead us to be in that position. The consequence of that would be what's termed as intervention and investigation. That would mean that there'd be a short piece of work done by consultancy engaged nationally, paid for by the ICB, to look at the things that we would need to put in place in order to get back to a deliverable position. As the board will be aware, the plan that we submitted did have some significant risk in it. But we are continuing to assure ourselves by meeting regularly, both in terms of discussion with CFOs, which is happening on a monthly basis, going through, as I said before, the monthly financial and workforce positions, and also detailed conversation and assurance at the system leadership group, where chief executives are also joining in that conversation. I'll leave it at that point. If there are any detailed questions or queries or any further information that's required, happy to do so.
Thank you, Bill. Are there any questions for Bill on the financial position of the ICB or the ICS? Graham?
Can't quite believe I'm saying this because it is opposite from my normal thing about workforce and finance. In the IPQR report, we're actually now tracking below our planned headcount. Now, I don't know how that's arisen over the months year to date, but we've not seen that come through in the finance. Presumably, Bill, you would in due course, wouldn't you? Question?
We've asked organisations to look at that in detail. The latest position that I saw, and Piers can correct me if I'm wrong, was about a 538 reduction in FTEs as at the end of month 3, but an increase in expenditure of about £3 million. So we're trying to track those two things. There will be a bit of a timing gap. Individuals who leave in month would likely to be paid to the end of the month, but we don't think that fully explains the difference. So we're also looking at whether there are any incremental issues, whether there are any backdated pay awards, and also to look at that in terms of individual organisations. I think that the position that we're trying to uncover and understand most is the one in Torbay and South Devon, and because there does seem to be that disconnect. That's not to be critical, that's just to try and understand the data quality issues. We're pretty sure that the data that we've got are correct, so we need to understand the reason for the difference. I'm hopeful and would expect, and have had the conversation with CFOs, and I know that Piers had the same conversation with CPOs, that we expect this to be a time lag and that this will come right as we go through the course of the year. But I expect to be in a stronger position to comment on this as we get month 4 data.
Thanks, Bill. And I think it might be useful to just bring in Piers for a perspective on the workforce numbers as well. Thanks, Piers.
Yeah, I don't have an awful lot to add to what Bill said. It's a very comprehensive answer, actually. So everything Bill says is spot on. We know industrial action had played a feature as well. That was to the tune about 800,000 in the end for the end of month 3. There's a little bit straddling into month 4 as well, which would take it over 1 million, but that's a contributing factor. And just as Bill said, we're digging into it, and the comment I made earlier when we were talking about performance and workforce is that we have the intelligence and the connections within organisations to be able to dig into this quickly, which we haven't had before. And so the level of grip in organisations is so much better than it was, down to individual staff members, off framework or agency costs, long-term agency investments, those sorts of things. We know the name of the individuals that we're talking about. It's that sort of level of granularity. So we are digging into it, just as Bill said, and we will have a better, more comprehensive answer and understanding of it by the time we get to month 4 reporting. Just to give you some reassurance, so we are absolutely on that.
Thank you, Piers. And final comment on this from Mark, please.
Thank you, Chair. Just to confirm, nothing in contravention of what Bill's already set out, but we have written formally on the back of month 2 figures to the ICB and to Bill to set out our expectations, because we are extremely worried about the high risk that the system's facing, obviously, particularly the back-ended part of the efficiency savings, which Bill's already alluded to. So that's all set out, and there's a number of key milestones that need to be met over the coming weeks and months, and we'll be monitoring it very closely on a monthly basis with you.
Thanks, Mark. So in the context of the high risk around the financial plan, which Bill and others have highlighted throughout the meeting, and in the context of Bill's highlighting that the financial position that we're seeing in front of us today relates to an earlier version of the plan at an £85 million deficit, and that we now have an £80 million deficit target. In those contexts, is the board happy to take assurance that the financial position of NHS Devon is in accordance with the agreed plan, and that processes are in place to actively manage risks identified to the delivery of the year-end compliance with that plan? Thank you. Yes. Thank you. And in the same context, the ICS finance report for month 2, is the board happy to take assurance that the financial position of the One Devon integrated care system is in accordance with agreed plans, and that processes are in place to actively manage risks identified to the delivery of the year-end compliance with those plans? Graham.
Yes, happy to agree to that. I think it would be helpful at some point to see the calendarisation. We all recognise it is backloaded. I made the point very early on. About 16% of the year is gone, and yet we've already hit 32%, which I think is Mark's point. I think it would be really helpful if we had that calendarisation at some point, please.
Yeah, I think that's a helpful point. So if we add to this recommendation, Bill, would you be happy that if the next Finance and Performance Committee could take a look at that calendarisation and seek deeper assurance on the delivery of the year-end plan?
What I was actually going to suggest, Chair, is that the next FNPC we will provide a short report as per your request, but we'll also provide, if it's acceptable, the PowerPoint presentation that we use for the assurance meetings with each of the organisations, and that includes the profiling of the CIP by month and by quarter. So that will speak to the point that Graham made.
Thank you, Bill. Alison.
Just, Chair, in the context of what Bill said earlier about the risks, that specific recommendation, whether it could be minuted subject to acknowledgement of the risks outlined by the CFO, So I think, you know, it's the assurance, but also the understanding, the board's understanding of the risks.
Yeah, we will record that, Alison. I was trying to capture that in my statement around in the context of the risk which have been highlighted, so we'll make sure that we get the appropriate wording around that. Okay, thank you for that, and thank you, Bill. We now have the Integrated Quality Performance and Finance Report. Now, again, this is a report which was considered in detail at both the Quality and Patient Experience Committee and at the Finance and Performance Committee. But is there anything that you would wish to draw to the attention of the board, Anthony?
Yes, thank you, Chair. Just bearing in mind also large components of this have been picked up in the discussions this morning. There are two things I would like to raise. Firstly, around our continued improvement against no criteria to reside. It's important, I think, as a sort of testimony to joint and system working with our partners. And actually, not just because Kate is sitting next to me, but our continued improvement with no criteria to reside for Cornwall patients residing at UHP. Pleased to say, actually, in the last couple of days, we've seen that come down almost to single figures. So bearing in mind where we were a few months ago, thank you very much, and I think I'd just like to acknowledge that. The other element I would like to just draw attention to is around community waiting lists, and although we have spoken at length about children and young people within that, there are large components that are adult services. We are changing our approach dramatically in terms of the oversight of those community waiting lists, and bearing in mind that half of the patients sitting on that list of over 33,000 patients are around MSK, podiatry and rehab services. We think there are further opportunities to do something significant within that. There is a large validation element which we'll be going through with each of our providers, and certainly we'll be changing the oversight and the management of that within the ICB. Formerly this sat with the community team, and I think there's been obviously some casualties as staff have left that particular area, and we need to make sure there is strengthened oversight. So we'll be putting that in place over the next couple of weeks and coming back with a clear plan as to what the trajectory needs to look like.
Thank you, Anthony. Are there any observations on the IQPR or questions for Anthony? So if not, then let's note that Anthony has highlighted the significant improvement in the no criteria to reside numbers across Devon and Cornwall, and thanks for highlighting that to us, Anthony. And I think also the board welcomes the new focus on community waiting lists. So we look forward to some further information on that at the Finance and Performance Committee and at the board in future. So thank you for that. We're asked to note the current performance position against key performance indicators measured in the IQPR. Is the board happy to note that? Thank you. And we're asked to take assurance from the proposed approach to future performance management reporting set out in the report. Thank you. We now move on to the board assurance framework. Philippa, can you take us into this item, please?
Thank you. I think there's obviously, I assume people have read the report, but I think there are 2 points to raise. The first being that now that the annual plan objectives have been signed off, we will be doing work to make sure that those are reflected within the board assurance framework, and that we have an integrated approach to reporting on delivery against mitigating actions. I think that's a key change that you'll see in the BAF going forward. In terms of the current risks set out in the BAF, I think it's worth highlighting that we've seen a change to the ratings of 2 of the risks. We've seen a change to the rating of the risk in relation to preventing ill health and reducing health inequalities, and we've seen an increase in the risk rating of that risk in light of the financial allocation for work in this space. But we have also seen a change in the risk rating in relation to leadership and capability, and we've seen a lowering of that risk in light of the work that we've been taking forward in the establishment of the system leadership group and the locality planning and development meetings. So I think that's probably sufficient introduction. Happy to take any questions.
Thanks, Philippa, and thank you for highlighting those points. Any questions for Philippa? Graham?
Preventing ill health and reducing inequalities has gone up as a risk because of funding. That's counter to the new government's policy. Are we concerned about that?
So I might just ask the Chief Executive to respond to that point.
Yeah, I think it's reasonable to say we are concerned about it. I think the process we've been through to settle the financial plan did mean there were some difficult choices that had to be made. These are not choices I would like us to be in a position of making in the long term. So I'm hoping we will be able to get back on track with this in future years. But at the time, there was no other choice.
Thanks, Graham. Thanks, Steve. Frank.
It's the financing use of resources again. Given what we've said about them today, is 12 an accurate figure, or should it be higher?
So what I would suggest on that, unless Bill wants to say anything now, is that maybe we take that question into the Finance and Performance Committee and do a full assessment of that risk at the next meeting, which will be in 2 or 3 weeks' time, I think. Would that be a acceptable way of taking that, Philippa? Yeah. Thank you. Thanks for the question, Frank. Sorry, Bill. Didn't see your hand raised there. Thank you. Come in.
That's okay. It's a bit late. Sorry. I think Frank makes a good point. I think we should look at that. I think potentially we should review the impact as opposed to likelihood. I think that an impact of 4 might be something that we want to think about. So I do think it's worth having another look at, and I think that's the right way to do it.
Thank you, Bill. So if there's no other questions, we're asked to...
There's one final thing.
Sorry, one final thing. Sorry, Phil.
Apologies, I omitted it in my introduction. So I think one of the key the reasons we put the board assurance framework towards the end of the meeting is to give the board assurance that the issues that are being discussed through the meeting are being picked up through the BAF. Obviously we've talked about a number of these issues in the meeting. However, I do wonder whether there's something that the board would like us to take away as part of an action that we had previously in looking at children and young people, to think about whether or not there's a BAF risk in relation to that. So I was wondering whether that was an action the board would like us to take away to think about.
I think that's a good suggestion, Philippa. So we're asked to take away the risk around children and young people in terms of how we incorporate that into the board assurance framework. If everyone's happy to do that. So is the board happy to approve the latest iteration of the 24-25 BAF risks to achieving the strategic objectives of NHS Devon, subject to some further work around the children and young people risk, and subject to the Finance and Performance Committee taking a closer look at the financial risk? Okay, thank you very much. We're on to the section of working in partners, and we have a report from the Cornwall and Isles of Scilly. Kate, is there anything you want to draw to the attention of the board from your report?
Thank you. I wouldn't mind some feedback from you, not necessarily in the board meeting, but outside of it, around whether our Caring Where It Matters document makes sense to you, because we want to use this to communicate with our people about the work we're doing around Cornwall and the Isles of Scilly. It's very tactical, as you can see, so the conversation you've all been having around where are children and what about prevention comes very much through the document when you read it. But I would just like to, the elements of our ICB annual assessment. So when we're talking about channel shift, we're not just talking about left shift, we're talking about sector shift. So it's not necessarily giving money to NHS or statutory services, it's around the use of our voluntary and non-statutory service. Around developing novel and innovative solutions, we've seen our voluntary sector organisation step forward with non-CQC registered services, which are amazing for getting people home, keeping them there and connecting them with communities. Our patient and public voices shaping, we've had more than 10,000 community conversations, and we're now moving into very targeted discussions around expert reference groups that are attached to our CRGs, so 200 people talking to us about diabetes. And this is taking us much more into place-based work, so our plan for 25-26 will be less about institutions and will be much more about place and life than it is around ill health. But it would be great to get some feedback from you outside the meeting. Thank you.
Thanks, Kate. I'm sure we'll all be happy to provide some feedback, and thanks for sharing the documentation with us. Are there any questions for Kate? Frank?
Not a question, but in terms of feedback, I think it's brilliant. And absolutely the right direction of travel.
Thank you. Sheena?
Ditto, I was actually going to say that. I've been looking through it. And for us, what I really like is the simplicity, the fact that you actually identify the cause of your problem and then your solutions are related to that. So there's a nice thread going through. But I also really like your focus on frailty. And I think we could just look at it.
Thanks, Sheena. So let's note the report from Cornwall and the Isles of Scilly. We're now moving into the committee chair reports. Because of time, what I'm going to suggest here is that we take the reports as read, but just open up for questions on any of them. So first of all, the Quality and Patient Experience Committees of the 13th of June and the 11th of July. Are there any points which anyone wants to raise with Tandy? Okay, if not, then we take assurance from those committee reports. We next have the Finance and Performance Committee report of the 13th of June, which is from me as chair of that committee. Are there any points or questions that anyone wants to raise with me relating to that report? Okay, if not, we take assurance from that report. On the Primary Care Committee, we have a report from the 20th of June, so I'll ask if there are any questions around that for Judy, but I also know, Judy, that you want...
I don't deal with those matters.
Okay, all right, then we'll just leave it. Are there any questions relating to the report from the Primary Care Committee of the 20th of June? Okay, thanks very much. And then we move to the Audit and Risk Committee of the 27th of June. Are there any questions for Graham on the points that are in that report relating to that committee?
And the 28th of May, it's 2.
Oh, I'm sorry, I missed that. Thank you, Graham. Yeah, there are two reports there. Okay, let's take assurance from that report from the committee. Thanks to all committee chairs for providing those reports to the meeting. We're now into the closing items and we're onto the action register. The first point to flag up on this, I think, is we're being asked to approve the closure of actions 37 and 24008B. So on action 37, it's reported that the Chief Delivery Officer the action was that the Chief Delivery Officer should review the orthopaedic pathway and barriers to an efficient, cost-effective and user-friendly pathway, and review of the specialist physiotherapist pathway to be brought back to a future board meeting. The response to that, dated the 10th of July 24, is that a report has been circulated to board members on that issue, and there is a proposal to close that action. Is everybody happy for us to do that? Okay, thank you. On action 24008B, this action was consideration to be given to whether the successful delivery of the organisational development plan should be included in NHS Devon's organisational objectives, and there's a response dated 17th of July 24 that this has now been incorporated into the annual plan and governance improvement plan, which we have reviewed earlier in this meeting. Is everyone happy to close that action? We also note the updates in respect of the remaining open actions. There is only one action where it seems to me the date has been passed, and that's action 68, which is primary care representation on the urgent and emergency care board to be considered when its terms of reference are being reviewed and an update be provided. I see that the note says the terms of reference will be reviewed by the end of September. Are we all content with that extension to the date? Okay, thank you very much. We're into questions from members of the public. We do have a number of very detailed questions relating to the Teignmouth Health and Wellbeing session. Because of the length of those questions and the amount of detail in them, what we are proposing is that we will compile a written response to each of those questions, and that we will then publish those written responses so that they are available to the public. Would the board be happy with that approach to those questions? Okay, thank you very much. And I think we're into AOB now. Any other business? I won't go around the table individually, but if anyone has any other business, would you like to just raise your hand and I can bring you in? Okay, so at that point then, let's note there's no other business, and we can close this board meeting in public session and move into the private session of the board. So thank you very much, everyone, for being here. Thank you for all the contributions. Thank you for the high quality of the reports which have been produced for the meeting, and we'll see you at the next meeting. Thank you.